And therefore, the disease surveillance team, together with the FELTIP team, came together and formed a team to be able to go and investigate to find out what the causes of the outbreak could have been. So maybe just to give you a quick situation of cholera in Kenya. After this wedding, looking at this, this is the epidemic graph for the cholera situation currently in Kenya. As we're speaking, the cholera outbreak is still ongoing. So maybe just a quick background. Kenya has had several outbreaks of cholera since 1971, and the largest was around 1998, with over 50,000 cases being affected. But the latest one started in 2022 at around October, and this is where the wedding happened on 8th of October. And since the wedding, we've had cases being reported daily until currently. We still have cases in some of the counties being reported. And this is how the cases have been reported, with the introduction of oral cholera vaccine coming in at around February this year and also in July this year. But so far we've had 12,122 cases with a case fatality rate of 1.7, and 27 counties out of the 47 at 54% reporting cases. So the objectives for the outbreak when we went out was to determine the magnitude of the outbreak and also characterize the cases, have a laboratory confirmation of the outbreak, and also identify the risk factors. During the case, during the outbreak investigation, we defined a case as anyone, for suspected cases, anyone who was presenting with profuse watery diarrhea of an acute onset and had attended the wedding. And then probable cases were those who are epidemiologically linked to any confirmed case, while confirmed cases were those that had a confirmed diagnosis from the lab for Vibrio cholerae. So we investigated in the two counties, and we did active case search and contact tracing using a preset questionnaire, and we also did abstraction of data from files for patients who had been admitted. We did also pick samples for laboratory tests. We picked human stool isolates and also water samples. And for the data that we collected, we were able to analyze it using Stata, and we did both descriptive, bivariate, and multivariate analysis. So the results, the wedding was a private wedding with around 500 invitees, and we were able to interview 113 people who attended the wedding, and out of the 113 that we interviewed, 73 were cases, while 40 were non-cases. Of the 73 cases, 2 did not attend the wedding. And at the time we were doing the investigation, we had 19 being admitted, but during the investigation, only 2 were still in the wards. Looking at the cases on how they were presenting, on the date of the wedding, which was on 8th, we had people who presented at 15, and then it peaked on the second day, and the cases were there until when around 10th, that's when the last case from the wedding was reported, 9 days after the wedding. The distribution, it was a wedding and attendees had come from all over the country, but the cases came from 6 counties, and they were distributed as follows. We had cases from Kiambu, the host county for the wedding, from Nairobi, and the other counties. But the highest came from Kiambu, where the wedding was being held. So looking at the distribution per age group and gender, the 50 to 59 age group had the most cases, and the male were more than the female. The clinical presentations, most cases presented with diarrhea, with other symptoms like abdominal pain, cramps, vomiting, and fever. I had mentioned that for hospitalization, 19 cases were admitted, while 52 were treated as outpatients, and of the 19, by the time we were doing the investigation, only 2 were still in the facility. For laboratory diagnosis, these patients had already been in hospital and they had been done for RDT and culture. So by the time we were getting into the field, we just picked the stool isolates and send it to the National Reference Lab for confirmation. And out of the 10 that we picked, all of them tested positive for cholera 01 or GAWA. And we also did antibiotic sensitivity, and 2 samples had antibiotic resistance to ampicillin and chloramphenicol. For the water that we had picked to test, we picked samples for the bottled water they used at the wedding, and also water at the wedding venue, and these ones were fit for human consumption, while the one that we picked from the caterer's tank had cholera coliforms. Despite it having cholera, the water at the caterer having cholera coliforms, when we did analysis for risk factors, the water, the foods and the salads, all of them did not show any statistical significance, though age, being aged between 51 to 89 was a risk factor with a risk ratio of 2.6. The others, like eating grilled chicken and roast goat, was associated with the outbreak, but it wasn't statistically significant. So we, as I had mentioned, that cases develop symptoms between 3 to 9 hours, and this could be an indication of a point source infection. The age group 50 to 59 was the most affected. This could be because at that age there's always sometimes reduced immunity, and it's also in agreement with other studies that have been done that the Ogawa subtype normally affects the older age group. And then the most common symptom was severe dehydration, and this could be also due to the prognosis of the disease. With cholera, there's a lot of diarrhea, you're losing a lot of fluids, and that could be the reason why it was the most common. And Vibrio Ogawa was responsible for the outbreak. In conclusion, there was a confirmed cholera outbreak affecting 6 counties in Kenya, and the investigation indicated that there was a presence of fecal contamination in the piped water being used by the caterer, and there were asymptomatic cases in the population, because when we did the interviews, there are some who had not presented with any, but when they presented themselves to the facilities to be tested, they were found to have cholera. So we recommended that the affected counties scale up active case search, as there were asymptomatic cases in the population. And then we also recommended that the ministry put all public health units on emergency alert so that they can be able to catch any new cases. And then we also recommended that there will be collaboration between the Ministry of Health and the Ministry of Water and Sanitation, just to help contain the food vendors and the unregistered water suppliers. And lastly, we recommended that emergency operations centers strengthen awareness among the communities and also among the healthcare workers. So after this, the public health action that was taken is that there's been an ongoing educational system for food handlers in both Kiambu and Nairobi County, and it has been rolled out to the whole county, because currently we have 27 counties that are affected. And then we've also assisted to develop a standardized inspection checklist for food establishments, and there's ongoing capacity building for healthcare workers to help in preventing new cholera outbreaks. Currently, we are planning for a 3rd oral cholera vaccination. Those are my references, and I acknowledge FELTIP Kenya and the Ministry of Health Kenya for the support. Thank you.
Okay, thank you very much, Serafina. We know that Kenya has been struggling with a cholera outbreak for quite a long time now, and we are going to hear from our next speaker, Sarah Nchoko, about a cholera outbreak in special institutions in Machakos County in Kenya. Let's see if we can get your presentation up. Maybe you can help.
So they're in this folder.
in special institutions in Machakos County, November 2022. Cholera is an acute epidemic-prone disease. It's caused by ingestion of food or water contaminated with Vibrio cholerae. And Kenya has experienced epidemics since 1971. The Lakes County, GK Main Prison, and School for the Deaf were among the affected institutions. Factors for the transmission were unknown. Therefore, the Ministry of Health dispatched a national team to respond. In the field, the team was guided by 3 objectives. 1, to determine the magnitude of cholera outbreak in Machakos School for the Deaf and Machakos GK Main Prison, Machakos County 2022, to characterize the cholera cases, to determine possible factors associated with the outbreak in Machakos School for the Deaf and Machakos GK Main Prison, Machakos County 2022. At the investigation site was the GK Main Prison and School for the Deaf in Machakos County. The population in the GK Prison is 900 and in School for the Deaf is 374. Both institutions are enclosed institution. The School for the Deaf is a boarding school. The cases at the School for the Deaf were 174 and in the prison they were 40. Methodology, we visited the institutions that were affected in Machakos County. We did a record review of records. We abstracted data from the inpatient and outpatient registers. We interviewed prison and Machakos School for the Deaf and Machakos Water, Sewerage and Company admins and the County Director of Health, prisons and pupils who developed the signs and symptoms. Among the samples that were collected for testing included rectal swabs and water samples were also taken for analysis. The case definition, for suspected case definition was any person presenting with acute onset of watery diarrhea with at least 3 motions in 24 hours, who was a resident of Machakos GK Prison and Machakos School for the Deaf between 1st October to 25th of November 2022. The probable case definition was any suspected case epidemiologically linked with a confirmed case. And for the confirmed case definition was a laboratory isolation of Vibrio cholerae serotype 01 or 0139 in stool culture from a person meeting the probable or suspected case definition. We collected data using Excel. Means and frequency and proportions were calculated in univariate analysis. Associations were calculated by variate analysis and variables with p-value less than 0.2 were subjected to multivariate logistic regression. Variables with p-value less than 0.05 were considered statistically significant at the multivariate logistic regression. We sought approval from the Ministry of Health, the National Prison Headquarters, the School for the Deaf Management. We also sought consent and assent from the prisoners and students in the institutions, assented by the relevant authorities. Results. We reviewed and enlisted 214 records. Males were the majority at 54.2%. Of the total tested, 62.9 were Vibrio cholerae positive by culture, serotype Ogawa. Machakos GK Prison contributed the highest at 57.1%. The most affected age group was 31 to 40 at 37%. The case fatality rate was at 0.4%, and the attack rate was high in Machakos School for the Deaf at 46.5%. The epic curve showed the onset of cases being on 5th November, with the peak being on 7th November, and then there was a decline of cases that followed. We also looked at the distribution of cases among the general population, just to determine whether during the time the institutions were reporting, whether the general population was also reporting cases, so that we can try to see whether the cases came from outside the general population. So the events that surrounded the outbreak, following an interview from the administration, the 2 institutions had no water, and there was a tanker that supplied water. The tanker supplied water on 4th in the prisons, and 4th November 2022 at 2 p.m. The onset of diarrhea started the same day at 5 p.m. Upon further interview, all the prisoners had meals from the institutions and used tap water. The same Tanga supplied water to the school for the deaf on 5th November 2022 at 4 p.m. Onset of diarrhea started the same day at around 11 p.m. The students had meals from the institutions. They used tap water and also water from the borehole. Water analysis from 6 different drawing points showed that they had high contamination with coliforms and E. coli and were unfit for human consumption. Possible factors for the spread of cholera in the school for the deaf and prisons. Those who were in contact with the case, the odds of infection was 6 times more of being a case, while also those who reported not washing hands before feeding, the odds of infections was 7 times more among them. And both were statistically significant as independent factors that could have contributed to the spread of outbreak in the institutions. Discussion analysis of the demographic showed that most cases were in the age group of 10 to 20 years. A study done in Kenya recorded a high number of cases in person less than 20 years. This may be due to ignorance in maintaining good hygiene practices. Males were the most affected gender, and majority of the cases were caused by Vibrio cholerae 01 subtype Ogawa. Similar findings reported in other studies as the variant causing most of the outbreaks. The epidemic curve showed a point source outbreak, and Machakos prison contributed a high number of confirmed cases. The CFR of less than 1% implies timely management of cases in the vulnerable population. In conclusion, there was a confirmed cholera outbreak affecting the school for the deaf and prisons in Machakos County, and safe water and hygiene among the potential source of cholera spread. We recommended the Ministry of Health to intensify cholera vaccination in the country, and the Department of Health Machakos County to sensitize water vendors on distribution of clean water, improve access to clean drinking water, create awareness on the importance of treating water refilled by tangas, improve sanitation facility, and encourage personal hygiene. The public health action that took place, there was a setup of temporary units in the treatment units in the institutions to contain the outbreak at source, and maybe that's why we had a sharp decline in the epi curve, and also dissemination of findings to the school and prison administration, Department of Health Machakos County, Ministry of Health, Division of Disease Surveillance and Response, and Kenya FENTEP. There was also sensitization of cholera outbreak to the staffs, and also sensitization of hand hygiene to pupils and prisoners. There was also enhanced surveillance on food premises that surrounded the institutions, and distribution of cholera tabs to the community around the institutions. Vaccination also took place. Those are my reference, and I acknowledge the Ministry of Health, Kenya FELTEP, and also Machakos County. Thank you.
Thank you so much to Sarah. So now we've heard about cholera in Kenya, and we're going to be moving on to an outbreak of foodborne illness associated with pentobarbital contaminated horse meat, Havana Informal Settlement, Windhoek, Namibia. And this will be Monica Amunyela. And I just want to thank our presenters for keeping to time. Very well done.
Good afternoon, ladies and gentlemen. My name is Monica Amunyela. I'm from Namibia, and I'm going to present to you an outbreak investigation of foodborne illness associated with pentobarbital contaminated horse meat in Havana Informal Settlement, Windhoek, Namibia, April 2020. Before we dive into this presentation, I would like to introduce the house to the term pentobarbital, which is a drug mostly used in veterinary settings to sedate animals or to induce painless death. The presentation will follow the following structure. Foodborne illnesses are caused by ingesting contaminated food, and they contribute significantly to the global burden of disease and mortality, for which they cause over 200 diseases, and WHO has estimated that over 600, or rather about 600 people fall ill following consumption of contaminated food, and 420,000 of these die from these illnesses. Even though children under 5 make only 9% of the total global population, they are the mostly affected by foodborne illnesses, and the highest per capita burden of these illnesses are burdened by the African continent. Foodborne illnesses cause considerable socio-economic impacts, such as putting strains on healthcare systems, as well as threatening food security, trade, and tourism. On 8 April 2020, we received numerous alerts from the National COVID-19 Hotline, where a number of ill children as well as pets were reported to have been sick, and the community suspected it was COVID-19. We have therefore investigated to verify the existence of this outbreak, to identify the source and the mode of transmission, to determine the magnitude, as well as to implement control measures. We conducted a descriptive case series study among the residents of Havana Informal Settlement, where we defined a case as a resident or visitor in Havana Informal Settlement who developed acute onset of any two of the following symptoms: vomiting, diarrhea, headache, unconsciousness, and steady gait between 7 and 11 April 2020. The map below is of Namibia, showing Windhoek, the capital city, where Havana Informal Settlement is. The settlement is characterized by very minimal municipal services, and the majority of the population live in absolute poverty. This is just a picture showing the housing condition in Havana Informal Settlement, as well as residents collecting water at the communal tap. We collected data primarily through focus group discussion with guardians of the sick children. We have collected food history intake on a line list, and we conducted a face-to-face interview with the meat vendor. Of the above methods, we have conducted active case search in the community as well as the local clinic. We did an environmental assessment at the implicated landfill, and we finally had a telephonic interview with a vet who dumped the horse carcass at the landfill. This is just a picture of the team conducting field work. Ladies and gentlemen, our investigation yielded the following results. 30 people from 6 households ate horse meat that was sold to them by a local vendor on 7 April. The mean age was 29 years old, of which the males were more than 50%. The majority were adults and only 17% were employed. When we probed further into the food intake history, we have found out that the horse heart was prepared separately. An elder in the household perceived that it was not edible, and then she instructed the children to throw it out. But instead, they shared it among themselves and their pets. 7 children ate the meat, and 5 got ill, with the total case fatality rate of 16.7 and a food-specific attack rate of 71.4%. 4 cats and 2 dogs that were given the meat also got sick, and the team observed how they displayed weakness and an unsteady gait. Ladies and gentlemen, I now present to you the case series of the 5 children who got ill following the consumption of contaminated horse meat. On 7 April 2020, around 6 p.m., just after the meal was shared between 12 and 14 p.m., the index case, who happened to be a 6-year-old female, developed diarrhea. She started vomiting, she complained of headache, and had an unsteady gait and eventually became unconscious. In the early morning hours of 8 April, case number 2 and 3, who happened to be males and both aged 10 years old, started vomiting, had diarrhea, developed an unsteady gait, and case number 2 became unconscious. Subsequently, case number 4 was reported around 4 to 5 a.m., who happened to be a 9-year-old female. She became nauseous, started vomiting, and had diarrhea. The last case recorded was that of an 8-year-old male who developed headache, nausea, and vomiting around 6 to 7 a.m. As soon as the call was received in the call center on 8 April 2020 around 11 a.m., the rapid response team was deployed and all children were taken to the hospital and they got admitted. This is just a picture of the children being loaded so that they are taken to the hospital. We got hold of the vendor who sold the meat to this household, and we found out that the meat was scavenged from a local municipal landfill. At the landfill, we found out that the carcass was dumped on by a vet on 6 April and was buried in about a 1-meter deep trench, for which then the scavenger entered the landfill through the fence instead of the normal entry, which is the gate, because it's not allowed, and then they exhumed the carcass between the night of 6 April and the early morning hours of 7 April. We have observed that the fence is vandalized and we could see the scavengers present on site. This is just a picture of a snapshot of part of Windhoek where the meat was sourced, as well as where the meat was eaten, and it shows that the distance between the 2 points is more than 18 kilometers. Further interviews that we had with the veterinary who dumped the horse carcass, we found out that the horse was sick with acute colic, and he euthanized it with 140 milliliters of pentobarbital, of which he indicated that he administered the first dose to sedate the animal and then administered an additional one that then put the horse to peaceful death. We then followed up with the children and we found that they were discharged from the hospital 3 days later. No additional cases were reported, and we didn't receive any reports of fatalities from these incidents. Ladies and gentlemen, we found that only those who consumed the hard hot got sick, and this could only be explained to the fact that when the pentobarbital is injected in the vein, it goes straight to the heart. So it could be that the highest concentration was in the heart, and that's the part that the sick children and the pets had in common. We conducted some literature and found that cases exposed to pentobarbital in the USA and Canada had more severe symptoms than observed among these children, and this could be explained to the fact that the 2 studies, the pentobarbital was administered directly into their systems, not through food. Ladies and gentlemen, we did not find any leftover meat at this house. nor did we find the carcass as it was reburied at the burial site. Therefore, we could not collect any laboratory symptom to rule out any other cause of the disease, and we conclude that the likely cause of illness in these children was consumption of horse meat contaminated with pentobarbital. We recommended that the landfill staff handle all dumped animal carcasses with unknown cause of death as hazardous. We recommend that all stakeholders disposing of animal carcasses disclose the cause of death. We recommended to the municipality of Windhoek to immediately fix the vandalized fence, and we recommend to the environmental health practitioners to intensify health education on food safety. We informed the treating doctor about the cause of illness so that they make proper diagnosis. We conducted food safety education with 19 people from the affected households. We conducted health education on safe disposal of carcasses with 4 staff at the landfill. The accompanying vet took the pets to their clinic, and this was a vital thing to do since we are moving in the One Health approach. This is some of the materials that were consulted during this study. I do acknowledge the following institutions, and I thank you.
Okay, thank you so much, Monica. I think this is the first foodborne outbreak associated with horse meat that I've ever heard about. So very interesting. Our next speaker is going to be Adam Anas, and he's going to present to us on the prevalence and trends of typhoid fever in East Mamprusi District 2022. Let me see if I can get your presentation. Okay. Thank you.
Good afternoon, and I welcome you to the East Mamprusi District in Ghana, where I'll be talking about the trends of typhoid fever in the district in 2022. Typhoid fever is a bacterial infection that is caused by Salmonella typhi, which is mostly transmitted through contaminated food and water. And so an important risk factor is the lack or access to potable water. And it is prevalent among impoverished populations and also among children mostly under 50 years. It is a major cause of morbidity and mortality, especially in lower and middle income countries, and it has the ability in causing complications that can result in death. In Ghana, typhoid fever is among the leading causes of morbidity in our health facilities. And in East Mamprusi in particular, there were some sporadic outbreaks that were recorded in 2019 and 2021. This study therefore analyzed data from 2017 to 2021 to determine the incidence of typhoid fever and also characterize cases by person, place, and time. The study was a descriptive secondary data analysis, and the data was collected in May 2022 in the East Mamprusi district, and the short is one of the communities which recorded the outbreaks in 2021. East Mamprusi district is one of the districts in the northeast region of Ghana, and it has a total population of about 188,000. It is subdivided into 5 sub-districts with 14 health facilities. About 76% of the communities have been declared open defecation free, and the major sources of water include dams, streams, and boreholes. Most of the people are involved in agriculture, peasant farming, and most of the women are also involved in petty trading. Persons who attended health facilities and were diagnosed with typhoid fever using blood or stool culture and also through without test with clinical presentation were considered as part of the study population. And so we reviewed the consulting room registers, the laboratory registers, and the admission and discharge registers, and we collected data on demographic, laboratory, and hospitalization status of the cases. We analyzed the data using Excel, and we calculated percentages and rates, and we also generated a map using QGIS. We sought permission from the health authorities in the district. We observed from this study that the testing rate for typhoid fever was low in 2017, and by 2021 it has increased to 61.8%. We also observed that the case fatality rate was very high, and by 2021 it has also seen a significant reduction to 2.9%. Typhoid fever cases per 10,000 population have also seen some increase considering the period from 2017 to 2021, with the highest being in 2020 with a record of 46.5 per 10,000 population. The disease was prevalent among females and also in populations 30 to 49 years. And the disease occurred throughout all the year for the period 2017 to 2021, and there are multiple peaks that were observed mostly within the rainy season. And the disease was also prevalent in the Gambaga sub-district, where we have the district capital. So typhoid fever, as we observe, have increased about 6.7 times from 2017 to 2021, and this may be as a result of increase in diagnostic services in the district. And this has the potential of bringing about economic burden to households and also to the health system. And this finding was also consistent with a similar study in the southwestern part of Ethiopia. We also observed that the working class were those who were affected, population 30 to 49 years from the working class in Ghana, and once they are the active population and they are getting down with the disease, it also has implication on the household economy. And also females are those mostly involved in house chores activities, and so they are those handling food, they are those handling water, and when they are getting infected, there is a risk of them transmitting the disease to other members of the family. And this study was also consistent with a similar one in Ghana, in Huehue. But the finding that the disease was more prevalent among population 30 to 49 years was not consistent with some other studies, which states that mostly it is children under 15 years who are infected with typhoid fever. The disease mostly peaked in the rainy season, and in the East Mamposi district, the rainy season begins from April all the way to October, and it peaks in July of every year. And so in July we see more of the cases because usually there is flooding because of the poor drainage system in the district. And somewhere around October, when the Bagre Dam is spilled in Burkina Faso, it affects some of the communities in the district. That also causes flooding and then infect the water sources. And as we saw in the background, the district is not having any, most of the communities don't have protected sources of water, so they get infected, and that might have contributed to increasing the cases during the rainy season. We also observed that the case fatality rate has seen significant improvement, and this may be attributed to the case management trainings that were conducted during the outbreak period in 2019. So in conclusion, typhoid fever cases did occur all year round with multiple peaks in the rainy seasons as observed. Working adults and females were those who were mostly affected, and the Gambaga sub-district, which hosts the district capital, is where we have the highest burden. We recommend that the district health directorate ensure that they expand diagnostic services to ensure that they are able to cover all suspected cases of typhoid fever, to ensure that they are tested, because we have seen the significant number of the cases are not tested. And we also recommend that the district assembly continue to improve access to potable water to all communities, and the health promotion unit should continue to do risk communication to ensure that people understand the control and preventive measures of typhoid fever. We engage some communities in public education. We also give coaching and supportive supervision to health staff to ensure that we strengthen the typhoid fever surveillance system, most especially in the area of documentation and reporting. And the district assembly also started the construction of boreholes and also the repair of those that are not functioning to ensure that the people have access to potable water. I acknowledge the following for the contribution they have made in ensuring that this study was successful. Thank you very much for your attention.
Thank you so much for that presentation on typhoid trends in Ghana. Our next speaker is Futi Gibbon-Sekwadi, who's going to talk about a prolonged outbreak of enteric fever associated with illegal miners in the city of Matlosana, South Africa, November 2020 to September 2022.
So I will be presenting on behalf of Puti. He is an epidemiologist who works in the Center for Enteric Diseases at the National Institute of Communicable Diseases in South Africa. And I'll be presenting on a prolonged outbreak of enteric fever among illegal miners in the city of Matlosana in South Africa from November 2020 to September 2022. Enteric fever is a potentially life-threatening bacterial infection caused by Salmonella enterica cerevars typhi or paratyphi A, B, or C. The infection often occurs through the fecal-oral route by ingesting contaminated food or water that's been contaminated by feces of an infected person. And about 10% of the persons recovering from enteric fever will intermittently shed for several weeks. And up to 4% of those infected will shed for over a year, and they are termed chronic carriers. In South Africa, the annual incidence of enteric fever caused by Salmonella typhi averaged between 0.1 per 100,000 between 2003 and 2018. And the last reported outbreak was in Dalmas in the province of Mpumalanga, and that was in 2005, where there were over 2,900 probable cases, or laboratory confirmed cases. The number of cases has declined over the last few decades, and outbreaks have become remarkably less common, although it is still endemic in South Africa. However, during 2021, there was an increase in the number of enteric fever cases that we observed, and an outbreak investigation was conducted to determine the magnitude and the source of the outbreak. We were actually alerted of the outbreak on the 24th of November 2021 from the Northwest Department of Health. And we assembled an outbreak team on the 8th of December 2021. Is that from? These graphs just speak to the previous slide. We can see the number of cases that have been reported over the years between 2003 to 2022. And we can see that the cases are relatively stable at around 150 cases per year up until 2021 and 2022. And if we look at the graph on the colored graph on the side of the screen, we can see, oh, excuse me, sorry. The number of cases proportionally attributed to Northwest Province, here seen in red, have increased in the years of 2021 and 2022. So we performed a cross-sectional descriptive study, and the data was collected either telephonically or through face-to-face interviews, either with cases or with proxies if the case was not available, and we used a standardized case investigation form. Enteric fever were diagnosed either blood culture, and they are then reported through the Notifier Medical Conditions System, and all isolates were then sent to the NICD for further characterization. So whole genome sequencing was performed, and the isolates were investigated with bioinformatic tools. Core genome multi-locus sequencing was used. And we also took samples from municipal taps close to the cases' homes to test and analyze the water samples. And we performed descriptive analysis using Microsoft Excel. So what we found was between January 2020 and September 22, there was a cluster of 53 genetically identical S. typhi isolates from 5 different provinces in South Africa. The cases that were reported from the Northwest Province represented 60% of the total 53. And thereafter it was Gauteng Province, Mpumalanga Province, the Free State, and KwaZulu-Natal representing the smaller proportions. And case investigation forms we were able to complete for 57% of the cases, meaning 30 of the 53. So the age group that accounted for the most cases was those between the ages of 15 and 49 years of age, and males comprised 68% of total cases. The most common symptoms were fatigue, diarrhea, abdominal pain, vomiting, and constipation, and 3 deaths were reported. Here we can see the minimum spanning tree drawn from the core genome multilocus sequencing of the isolates. Here the circular nodes each represent the isolates. Isolates with less than 5 allelic differences are then collapsed together to make one circular node. So the larger the node, the more isolates from the province. And here we can see Northwest Province contributing the most. Here we have our epi curve from the investigation, and we've separated by job type or job occupation. Males comprise 68% of the total cases. Of these, 72% were within the working age group of around 15 to 49 years of age, with a median age of 31 years. And of the 26 males within that age group, 54%, or 14 of them, worked in illegal gold mines in a specific shaft in the Northwest Province, and they're called zamazamas in South Africa. So if we have just a slightly deeper look at the epi curve, the first cluster of cases that we can see between October to December in 2020 was a family cluster. The index case had traveled and lived briefly in Mozambique with her boyfriend, and they lived in a rural area there where they practiced open defecation and they accessed their water from an open source well. She became ill while still there and traveled back to Klerksdorp, where she stayed with her family initially, and then when she became very ill, she went to hospital. She came into contact there with her father, her sister-in-law, and her nephew. And unfortunately her nephew passed away. And he's there in blue in one of the December cases. We also found out from her that her boyfriend was a zamazama himself. And then we see the first case who confirmed that he was a zamazama in April of 2021. He was from Northwest Province. The case we see there in red in June 2021 was a case from Gauteng. We actually interviewed his sister as a proxy, but she confirmed that he was working in Northwest Province as a zamazama at the time. And in September 2021, that was also a case from Gauteng, who had also been working in Northwest Province prior to falling ill. In November 2021, there was another zamazama working underground. In fact, we also interviewed him as a proxy for his friend who was working alongside him, who also unfortunately passed away. So those are those 2 cases in November. And then in December 2021, unfortunately, there was another child who was deceased. He was from the Free State, who interviewed the mother, and her brother was known to be a zamazama working in those mines in that time period. And so we continue to see the trend as we're investigating the cases. So all illegal miners reported illness onset while they were working underground. And the conditions underground, of course, is that there's no safe drinking water or ablution facilities, which led to contamination of the surface water that the miners were then using for eating, drinking, and for washing. There could be up to 300 illegal miners in a confined space at any given time, and they might stay underground for up to 12 months at a time without resurfacing, meaning they had no access to fresh water in that time. They were working up to 5 kilometers underground as well, and accessing the shafts illegally through mines on ropes, so not easy to get supplies to them. The cases of illness and deaths underground, they said, are common, and they report up to 5 deaths each week while they're working underground. And 5 of the municipal tap samples that we took, they were all free of S. typhi. So this outbreak primarily affected illegal gold miners, likely due to the consumption of contaminated groundwater while working in a gold shaft in the city of Matlosana. The prolonged outbreak was likely perpetuated by a persistent source of transmission to illegal miners due to the presence of a chronic carrier, and then also those who are acutely ill coming to the surface and infecting their families. And in addition, this investigation highlights the value of whole genome sequencing to detect clusters and to support epi investigations for enteric fever outbreaks. These are acknowledgements and some photos from the field. Thank you very much.
Thank you so much to Lee for presenting on behalf of Puti. Very interesting to learn about these different practices in different countries. Our last speaker is going to be Alhaji Mahmoud Konta, who's going to be talking about an epidemiologic investigation of food poisoning outbreak in Kenema district in Sierra Leone. Welcome.
Yeah, thank you, Sarah. Good afternoon, all. Alhaji Mahmoud Conte is the name, from Sierra Leone. FETP Intermediate. I'm here to present to you findings from the epidemiological investigation of food poisoning outbreak in Kenema City, July 2022. I shall be taking you through from introduction to recommendation. Food safety remains a public health challenge in resource-limited countries, including my country, Sierra Leone. Globally, food poisoning causes an estimated 600 million illnesses, 420 deaths annually. In Africa, 125 million foodborne causes illnesses are recorded, 180,000 deaths annually. Foodborne illnesses are common in Sierra Leone as in any other part of the world. On July 2022, the National Surveillance Unit in Freetown received a notification from the District Health Management Team in the eastern part of Sierra Leone about suspected cases of foodborne illnesses from a birthday party in Kenema City. The FETP, both the frontline and the intermediate trainees, were deployed to investigate the outbreak. We investigated to verify the diagnosis, to determine the magnitude and the possible source of the outbreak. For us to achieve the objectives, we conducted a case control study from 27th to 31st July 2022. 97 cases and 97 controls were enrolled. As you can see the map there, at the extreme end there is Sierra Leone. The red there is indicating the district where the outbreak occurred. And at the end here, we have also the specific sites of the Kenema City where the foodborne outbreak occurred. We use semi-structured questionnaire to collect demographic, clinical, and epidemiological data. For us to distinguish between cases and control, we use this outbreak case definition. Any person residing in Kenema City presenting with generalized body weakness, vomiting, or nausea from 25th July to 31st July 2022. And a control, any person who attended the graduation party or lives with a case patient and did not present with signs and symptoms suggestive of food poisoning within the same period. We use EP47 to analyze the demographic, clinical, and exposure variables. We also calculated the food-specific attack rate, bivariate and multivariate analysis to assess the food poisoning associated factors. At the bivariate level, p-value less 0.1 were included in the multivariate analysis. At multivariate level, p-value less 0.05 was considered statistically significant. Ladies and gentlemen, I now present to you the findings from our investigation. This is a descriptive summary of the cases in Kenema City, July 2022. We recorded 105 cases with one death of a 14-month-old child. 69% of those cases were females. 58% of those cases also were school-going pupils. Of the clinical signs and symptoms manifested by cases, generalized weakness, nausea, and vomiting were the most common among others. This shows the EpiCurve by date and time of symptoms onset, Kenema City, July 2022. The event took place on the 27th and the 26th July 2022 at the evening hours. The first case manifested signs and symptoms suggestive of food poisoning at around 5 p.m. Majority of the cases also presented with similar signs and symptoms on the same day at the peak at 7 p.m. having the highest peak. As I said, we calculated the full specific attack rate. Cake had the highest attack rate. People who ate cake were 3.3 more likely to come down with the disease than those that didn't eat the cake. This is an analysis of factors associated with the food poisoning in Kenema City. People who ate the cake were 7 times odds of having foodborne illnesses than those that didn't eat the cake. This was proved statistically significant at multivariate level. Ladies and gentlemen, from our investigations, the major symptoms presented were weakness, nausea, and vomiting, indicative of possible food contamination. Females and school-going pupils were also affected. Mainly this group of people were more exposed to the contaminated foods. The investigation found that majority of those who ate the cake fell ill, indicating possible contamination of the cake. Affected mainly this group of people. This study did not go without limitation to the contaminated foods. No specific investigation agent was actually identified of those who ate the cake isolated due to laboratory incapacity fell ill for testing possible food or environmental samples that were collected. This study did not go. Ladies and gentlemen, in conclusion, all the cases were party attendees who ate food from the same source or isolated due to laboratory incapacity contaminated for testing. Although the positive agent was not isolated or identified, the cake was identified. Ladies and gentlemen, in conclusion, possible factor. All the cases were party attendees who ate food from the same source. As part of the public actions we took, we sensitized the vendors for proper food handling. Was not retrieved or identified and discarded the cake was identified and immediately the outbreak started with this outbreak. We recommended to the social mobilization unit at the district health management team in Kenema district to sensitize the vendors for proper food handling, to educate Kenema communities on safe food handling and consumption to reduce foodborne illnesses and improve well-being. Immediately the outbreak. We also recommended to the Ministry of Health and partners. We recommended to the social mobilization unit at the district health management team and toxicological Kenema district, the eastern part of Sierra Leone, to educate Kenema communities on safe food handling and consumption. I want to acknowledge the following illnesses for their support during the outbreak investigation. We also recommended to the Ministry of Health and partners to build laboratory capacity for food and toxicological analysis.
Thank you so much to all of our speakers for these very interesting
These are the action photos.
We are now going to move into the question and answer
I want to
session.
acknowledge
I'd
the
like to
following
ask our speakers to come
for their
up,
support during the
behind
outbreak
me,
investigation.
please. And
Thank you very much.
we'll ask to get questions from the audience. We'll ask the the speakers to record their questions
for these
and then
very
answer them
interesting
at the end.
We are now going to
So,
move into the question
who
and
has
answer session.
the
I'd like
first
to
question?
ask our
Speakers to come up behind me, please. And we'll ask to get questions from the audience. We'll ask the
Thank you very
the
much for
speakers
the
to record
opportunity.
their
My name
questions
is Samuel.
and then
I want
answer
to
them
congratulate the
at the
presenters, all
end.
of them. I think they've
So,
done very well.
who has the first question?
Especially the fourth presenter was the name Anas. Yeah. The way you coordinated the public health actions, in fact, bringing on board various stakeholders. My name is Samuel. I think it's very good that we can learn from presenters, all of them. But I want to know, they've done very well. After implementing all these public health actions, the fourth presenter, have there been any observed change or let's say effect, for the way want of better word, after implementing this action. Bringing on board and to Serafina, I think it's very good that we can learn from categorical statements. I want to know in your conclusion that after implementing all these public health actions, fecal contamination of water sources, this wasn't seen or it wasn't conspicuous in your results. I don't know if I was the one who didn't see it. Can you show us the results? And also, you could have shared with us how you conducted the investigation, because I didn't quite see the methods well, so that we could learn from you as well, because the outbreak has persisted for long. I don't know if we want to know how you conducted your investigation. Thank you very much. And also,
you
could have shared with us how you conducted the investigation, because I didn't quite see the methods.
Good afternoon.
Well.
My name is Yalo from Namibia. I want to congratulate all the presenters. To the presenter number 1, the cholera outbreak at the wedding, I have to comment the presentation was well articulated. I just wanted clarity with regard to the index case. Were you able to profile? I want to congratulate all the presenters. Food handler, maybe the catering team? Was it a visitor? It's not really coming out clearly, because with the cholera outbreak at mass gathering, it's most of the time is associated.
To confirm. Thank you.
Thank you.
All right, please.
Okay, thank you so much. The attention was so much in front. My name is Dr. Kiza Henry from Uganda, and I want to thank the presenters. My question goes to the presentation from Sierra Leone. It was a case control study, which you did well. However, I have a concern. In a case control study, we are so much concerned about your definition, and I want a clarification on why do you base the definition of your case on only symptoms, given the recall bias and all those things that we know about a case control, and the importance of stating your case correctly so that we don't miss. Because yes, you stated in the limitations, but you have somewhere where you're like, the isolates were all negative, and then we'll proceed to present these results and make conclusions on them. Thank you.
Okay, thank you very much. And I have just one question. I'm sorry, we don't have time for another. I'm so sorry. But we do have to have a question, sorry, for each person, and I want to make sure that we cover everybody. So for our presenter from South Africa, I found that presentation very interesting. I was shocked to hear that people die underground, and I was wondering, what do they do with somebody when they die underground, and is it possible that the bodies are staying there and serving as a persistent source of infection? Thank you. I'm sorry, I think if you have additional questions, you will have to find the speakers afterwards. So why don't we go through in order of presentation. We'll start with Serafina.
Thank you, colleagues, for the inputs and your questions. I'll try to respond as fast as possible. In case I'm not able to respond to your question, maybe we can still get in touch out of the room. So for the first question that was asked around fecal contamination, I think you missed it on the slide on the answers, because the water from the caterer tank had fecal contamination as a result, and that's why it came into the conclusion and also even in the recommendations. Then for methodology, we did active case search, and we also did data abstraction from the facilities for those who had already been admitted. And we also did face-to-face interviews and phone calls for those who had already been discharged and had gone back to their homes far away from the county where the wedding was held. There was a question around the index case, if we did any profiling. By the time we were being notified, we had several cases already in hospitals. And so we we had several from the epidemic curve that on the first day we had several cases already. So we could not pinpoint and say this was the index case. But among the caterers, we also did, we asked for their clinical certificates, and all of them were okay. Could this have been led to the current cholera outbreak? We could say it's just added to the cases, but looking at the epidemic curve, since the wedding and when we started reporting those cases, they've been on. So it's still part of the same outbreak. Since 2022 October up to now, the cholera outbreak hasn't stopped. We have not had a day where cases have not been reported. And then lastly, there was a question on the 2 cases who didn't attend the wedding. Okay, there are 2 more. So there were 2 cases who didn't attend the wedding. One was a street child, and it was just around the vicinity of the wedding venue. So we suspected maybe they could have had access to the food, to the wedding food, because we didn't get to interview him. He passed on before we got to interview. Then the other person had traveled out of town. Yeah, the other person had traveled from Turkana, northern part of Kenya, and had come back home in Kiambu, and he was also found to have cholera. And then on resistance, yes, we did. In my methodology, I had said that we picked samples and we were testing. We did
a 12.7% reduction in cases. And we hope that this downward trend will continue. Thank you very much for listening and your questions.
Hello again, and thank you for the question. So just to summarize again, it was what happens if someone dies underground? Do they remain underground, or how are they retrieved? Could it be a source of persistent infection? So firstly, to respond, due to the legal nature of what's happening, there remains a lot that is unknown, to be sure. However, we do know from interviews that they're climbing through ventilation shafts out in the bush, down ropes that are tied with knots up to about 5 kilometers underground. So there's no ways they're bringing anyone up that route in all likelihood. It would be death-defying. So it seems what they have said, what some of them reported to us, was that there's actually arrangements with the legal mines where they can actually go down in the elevators of the legal mines and retrieve the bodies of the dead and bring them back up. Having said that, though, there are also incidents when there are dead bodies found on the surface in these areas. So to answer, it's unknown. We think they're retrieving the dead. And I must say, on interviewing these illegal miners, they are very tight as a community, if I can say that. And I do think they work in teams. And I think they do make sure that they bring up their team members. Yeah. Thank you.
Yeah, thank you very much for those very important questions. I want to start with the last question, asking why not involving the laboratory results in my definition for case and that of the control. I think you already helped me in answering my question because you cited one slide talking of a limitation, laboratory incapacity. But however, the cases and controls captured the what, the who, and where, and even when. So we bank on the signs and symptoms to be able to either track the cases, and the where, of course, the Kenema City, the when is 25th to 31st of July. This was actually the period we used to track the cases and also the controls. To the first question, yes, it was a case control studies. The 97 cases and the 97 controls were the study population. In the course of our investigation as trainees, we are also able to discover another 8 cases during our active case search facilities surrounding the area where the outbreak took place. So we added that 8. That was the 105 I mentioned, the descriptive, summary descriptive of the cases, which is the 105. So we only took 97 cases and 97 control as part of our study population. So thank you very much.
All right. Thank you so much to our speakers. Let's give them a hand. Very well done. This marks the end of our first session, and we are going to shift, I think, pretty quickly over to the poster session that is supposed to be in this room. Thanks to all of you for attending.
Thank you for connecting.
Well done.
Just an administrative announcement. There are barcodes on the walls there. Please get to the Q codes on the walls and make your evaluation of the sessions just before you leave. So all the other sessions are now switching over to the oral high posters. So you can now go to any session of your interest. We need to get in new people into this session.
Unless they...
We are already running behind the schedule, so let's move very fast. Thank you for attending this session. If you would like to continue to the next session in this hall, you are free to remain, but please feel free to go to all the other breakout rooms for the eye posters.
COVID-19 in Tigray region of Ethiopia. It is a cross-sectional study. To start with the introduction, on May 18, 2021, there were 4,000 fatalities and about 200,000 confirmed COVID-19 cases in Ethiopia. And the first confirmed case of COVID-19 in Ethiopia was on March 13, 2020. And in the study area, Tigray, there was 38 fatalities and a total of 6,188 COVID-19 cases. In Tigray, as well in Ethiopia, much was not known about the risk factors of deaths due to COVID-19. Therefore, this study aimed to identify the magnitude and risk factors of deaths in COVID-19 patients. This is the map of the Tigray region of Ethiopia. It is one of the 9 regions of the country. When I come to the method, we conducted facility-based cross-sectional study design with record review, and the entire database of COVID-19 patients admitted to all treatment centers were used. And data on mortality of COVID-19 cases were retrieved using data extraction technique from registers, patient charts, and line lists. And data were entered in EP data and analyzed using Species 21. And odds ratio with 95% confidence interval were estimated, and the level of significance was declared at P value of less than 0.05. When I come to our finding, the case fatality rate of the study was 0.6%, and among the total COVID-19 patients, those with age group of greater than 45 years of older age were 18.8 times more likely to die compared with the other age groups, and those private employees were 8.96 times more likely to die compared with the others, and those who have underlying illness were 16.57 times more likely to die compared with those who don't have underlying illness, and those who had history of close contact were 9.177 times more likely to die compared with the other counterpart. When I come to the conclusion, the case fatality rate due to COVID-19 was relatively low, being greater than 45 years of age, being privately employed, and having an underlying illness, and having close contact with COVID-19 was associated with deaths due to COVID-19. And we would like to recommend
to have special attention to the COVID-19 patients who had greater than 45 years of age and who have underlying illnesses. This is my presentation. Thank you.
Thank you, Kisanet. That was interesting. To be interesting to know why being privately employed was a risk factor. Sorry. Go back. So next we will have Prosi Nakito presenting on prevalence and predictors of self-medication for COVID-19.
Thank you so much. Before you, it is Nakito Prosi from Makerere University School of Public Health, presenting a topic entitled Prevalence and Predictors of Self-Medication for COVID-19 among slum dwellers in Jinja City, Uganda. Self-medication continues to be a public health challenge, and this has been exacerbated by COVID-19 pandemic. And when we go further to look at the prevalence at different levels globally, the prevalence ranged from 32 to 81%. And then when we came to Africa, according to literature, it ranged from 12 to 94%. And then Uganda, it ranged from 72 to 88%. These are some of the substances that were found in literature to be used for self-medication for COVID-19, and among them was moringa, turmeric, ginger, garlic, aloe vera, among others. This study set out to assess the prevalence and associated factors for self-medication for COVID-19 among slum dwellers in Jinja City, Uganda. And to be specific, it looked at the prevalence, and then also it looked at the predictors of self-medication. With this study, it was a cross-sectional study where it looked at all adults aged 18 years and above who are slum dwellers who reported having had confirmed COVID-19 due to PCR test, but then also the ones who self-reported for having COVID-19 in the year 2021. And it was a multi-stage sampling technique that was used among 517 participants. Quantitative data collection was used as a method where semi-structured questionnaires were used to collect data from these participants. And at this moment still, this is where we use the modified Anderson model, which looks at health service utilization to assess the factors that are associated with self-medication. At analysis stage, when it came to self-medication prevalence, we looked at, when it came to self-medication prevalence, we looked at as, no, I'm still here. When it came to self-medication prevalence, we analyzed using univariate analysis where the prevalence ratio was got. And then when it came to factors associated with self-medication, we did a bivariant and univariate analysis where simple modified Poisson regression was used, and both crude and adjusted prevalence ratios were used at a 95 confidence interval at a p-value less than or equal to 0.05. And then we fitted the models, and the model with the best goodness of fit was selected. When it came to our results, social demographic characteristic at univariate, we see that majority of the participants or respondents were aged between 26 to 35 age, and the median age was about 31, and majority of them were males, married, and majority of them still were Muslims, and had attained secondary education. Among the respondents, more than a half had a family income between 0 to 100,000 Ugandan shillings, which is an equivalent of $26. When it came to the prevalence of self-medication, it was found out that the prevalence was 87.2%, which was really high. And it was found out that respondents who are aware of the risk associated with self-medication were at 56.8%. So meaning as people continue to self-medicate, they were aware of the risk factors. When it came to the predictors of self-medication for COVID-19, we can see that being a female, that is sex, being a female, and then having an age 48, 46, 40 plus or above, and having anxiety and fear of being quarantined, having access to medical insurance, having access to internet and advertisement, and then also being influenced by friends and families, symptom severity in terms of either minor or severe, and then also being aware of any laws in regards to medicine use were found to be statistically significant to self-medication. We therefore concluded that prevalence of self-medication was very high despite being aware of its dangers, and therefore there is need to control for infodemia, and then also need to improve health insurance coverage in informal settlements like slums. Here we see some of the practices that were used for self-medication in Uganda. Around this time, we heard about Covidex, and that is the one you're seeing there in the picture. These are some of the herbs that are used for self-medication in these photos you're seeing. Yeah, thank you.
Thank you, Prosi. Next, we will have Peter Chris, yeah? I hope you're noting down the questions for our presenters. That's okay. So you just, yeah, so you just touch like that, it comes.
Hello, I am Peter Chris, an advanced field epidemiology fellowship fellow with the Uganda Public Health Fellowship Program. Here I will present to you a COVID-19 outbreak among refugees in Nyakabande Transit Center in Uganda in 2022. Refugee settings are susceptible to outbreaks, including COVID-19. Factors including overcrowding, inadequate access to clean water and soap, poor hygiene, make outbreaks spread faster than they would compared to other settings. COVID-19 control measures are similar to those in the general population among the refugees. These include mass testing, use of face masks, among others. In Uganda, on 28th March 2022, we received an influx of refugees from the neighboring Democratic Republic of Congo. These were mainly due to violent clashes, and when they came in, they were resettled in Nyakabande Transit Center. On 4th April, about a week later, the first COVID-19 case was detected among these refugees through mandatory screening. On 21st June, there was a media alert of 332 cumulative cases since April, which was received by the Ministry of Health. And on 26th June, the National Rapid Response Team had to join the response. We investigated this outbreak to establish the scope of the outbreak, identify risk factors for COVID-19 infection, and recommend measures to control and reduce COVID-19 infection. Nyakabande Transit Center in Figure 1 is about 18 kilometers from Nagana border, located in Soro District, which is represented in green, in southwest. COVID-19 screening was mandatory at both entry and exit of the transit center, as shown in the flowchart in Figure 2. Positives were isolated and retested after every 5 days, while negatives were allowed into the center or exit to the resettlement camps. In order to identify the cases, we defined a confirmed case as a positive COVID-19 antigen test in a resident of Nyakabande Transit Center between 1st March and 30th June. We then reviewed laboratory registers to collect data on total tests done and total positives at entry and exit. We also conducted environmental assessment to observe the sanitation and hygiene, availability of water, among others. To supplement environmental observations, we conducted key informant interviews Among those we interviewed were the clinical lead and the camp leadership. In this photo 1, we were conducting an interview with the clinical lead. From our descriptive analysis, out of 34,690 refugees registered, we identified 621 cases for an attack rate of 2%. No death was registered. As shown in Table 1, the COVID-19 positivity rate among refugees done at exit was 6 times that among refugees at entry. This suggested that refugees were infected with COVID-19 within the transit center. In Figure 3 is an epidemic curve of the outbreak. It had 3 successive peaks with approximately 1 incubation period apart, suggesting a propagated epidemic. From the environmental assessment, we observed crowding among refugees, for example in photo 2, and minimal and incorrect use of face masks among refugees, as can be seen in photo 3. Based on these findings, we hypothesized that COVID-19 infection among refugees was due to overcrowding and minimal use or minimal adherence to the COVID-19 control measures. We therefore focused to understand what changed within the transit center. This led us to conduct an unmatched case control study, and in this study we enrolled 42 cases and 127 controls. According to Table 2, the results show that cases and controls were comparable across sex, age, and education. Figure 4 illustrates that close contact with a symptomatic person increased the odds of COVID-19 infection by 10 times, and consistently using face masks significantly reduced the odds of infection by over 90%. In conclusion, COVID-19 outbreak in the transit center was due to overcrowding and inadequate face mask use among refugees. We did the following public health measures, which included disseminating findings to the district and transit center leadership. In photo 4, we're disseminating to the district leadership. Secondly, we promoted the ongoing distribution of face masks among refugees. And finally, we conducted refugee-led sensitization meetings to enhance face mask use among refugees. We acknowledge the following institutions. I thank you all.
La prochaine intervention concerne les déterminants de l'acceptabilité de la vaccination contre le Covid-19 dans une région du Burkina Faso par Aristide Compaoré. Vous avez 5 minutes.
Merci, mesdames, messieurs les modérateurs, mesdames, messieurs les évaluateurs, chers participants, bonjour. Je me nomme Aristide Compaoré, docteur vétérinaire et gradué FITP intermédiaire. J'ai l'honneur en ce jour de vous présenter les résultats sur les déterminants de l'acceptabilité de la vaccination Covid-19 dans les régions du centre-sud, sud-ouest, centre-ouest et du centre au Burkina Faso en juin 2022. Les premiers cas confirmés de Covid-19 ont été détectés au Burkina Faso le 9 mars 2020. Et depuis lors, 4 vaccins sont à la disposition de la population burkinabé. Mais force est de constater que moins de 12% de la population sont vaccinés contre la Covid-19. Et les raisons de cette faible acceptabilité sont peu connues. C'est ainsi que notre étude s'est proposée d'étudier les déterminants de l'acceptabilité de la vaccination contre la Covid-19 dans les régions du centre-sud, du sud-ouest et du centre-ouest au Burkina Faso en juin 2022. Ainsi, notre étude s'est déroulée du 20 au 31 juin 2022 et était de type transversal mix analytique. La population d'étude était celle des régions concernées, et plus précisément des districts de... Ok, slow down, ok. Ok. Ok, yes, ok. Ok, je disais que notre population d'études était celle des régions concernées, et plus précisément des districts de Boulmigou, de Bogodou, de Signoguin, de Gawa, de Réo, de Koudgou, de Sabou, de Po et de Manga. Elle a concerné au total 288 personnes qui ont été interviewées grâce à un formulaire électronique déployé sur ODK Collect. L'analyse des données a été effectuée à partir du logiciel EpiInfo 7.2.5 et l'étude s'est déroulée selon le respect des dispositions éthiques et déontologiques, le recueil du consentement oral et éclairé et du secret professionnel. Cette carte représente la disposition des différents districts suscités. Et cette étude représente le déroulement d'une interview dans la commune, dans le district de Manga en juin 2022. Quant aux résultats, le niveau d'instruction le plus rencontré était le secondaire et représentait 30,56% des enquêtés. Quant aux connaissances, 98,83% des enquêtés avaient une bonne connaissance sur le mode de prévention, 87,15% avaient une bonne connaissance sur le mode de transmission et seulement 6,6% connaissaient les vaccins disponibles. Quant aux attitudes et aux pratiques, 34,72% des enquêtés étaient vaccinés contre la COVID-19. 88,19% avaient une bonne perception des effets bénéfiques du vaccin et 63,83% acceptaient se faire vacciner dans les prochains jours. Les principales sources d'informations sur la COVID-19 étaient essentiellement la télévision et la radio. Quant aux facteurs associés, les hommes avaient 1,43 fois plus de chances d'accepter la vaccination contre la COVID. Ceux qui croyaient à l'efficacité du vaccin avaient une chance infinie d'accepter la vaccination contre la COVID, tandis que ceux qui percevaient les effets bénéfiques de la vaccination COVID-19 avaient 3 fois plus de chances d'accepter la vaccination contre la COVID-19. Mesdames, Messieurs les membres du jury, chers participants, le taux de vaccination contre la COVID-19 reste faible au Burkina Faso et l'hésitation face à cette vaccination demeure une réalité. La communication et la sensibilisation sur les effets bénéfiques de la vaccination contre la COVID-19 s'avèrent donc nécessaires. Les personnalités publiques âgées ayant fait la vaccination pourraient améliorer cette situation en tant que porte-flambeau des campagnes de vaccination, en tant que porte-flambeau des campagnes de sensibilisation en faveur de la vaccination contre la COVID-19. Mesdames, Messieurs les modérateurs, Mesdames, Messieurs les évaluateurs, chers participants, je vous remercie.
Thank you. How do you say merci? Merci. He was too fast, huh? But he said men were more likely to get the vaccine, right? So next we have Adesoji, please come to the front. Adesoji. Oh no, sorry. My Ethiopian neighbors. Or who is that? Are you the one? Who? Do we know him? He didn't come? Oh, okay. It's like I knew, eh? Okay. So Adesoji, please come to the front. Adesoji.
it touch screen?
Yes, yes.
It's not projecting yet. Good afternoon, ladies and gentlemen. My name is Adesojola Tunudikoya. I'm a fellowship graduate of Nigerian Epidemiology Viability Training Program. I'm glad to be here to share with you the result of our evaluation of COVID-19 system in Ogun State, April 2020 to May 2021. COVID-19 pandemic is caused by severe acute respiratory syndrome coronavirus 2 SARS-CoV-2, and there was a total of 69,621 suspected cases, among which 4,686 confirmed cases from April 2020 to May 2021 in Ogun State, Nigeria. Surveillance evaluation determines whether public health emergency has been monitored effectively. Achieving its objective of early detection and decision-making is being informed by the system data. An effective surveillance system is needed to effectively control disease outbreak. We assess the capacity of COVID-19 surveillance system for early detection of outbreak, monitor the spread and progress of pandemic, and effective measures instituted to control the outbreak. We use the Center for Disease Control updated guidelines for evaluating public health surveillance in Ogun State COVID-19 surveillance system. And this is the flowchart of the Ogun State surveillance system. The reporting starts from the community to the health facility, to the local government area disease surveillance notification officer, to the state, which is comprises of the state epidemiologist, incident manager, and the DSNO, to the national and the partners. And the feedbacks come from the partner to the national, to the states, to the LGA, DSNO, to the health facilities, and the community. We analyzed COVID-19 surveillance data from a period of April 2020 to May 2021 from the epidemiology unit of the Ministry of Health of Ogun State. We assessed the usefulness and the attributes of the surveillance system through key informant interviews of 45 surveillance officers. We used the evaluation method and scoring system to rate the performance of each quantitative indicators as follows: less than 60% poor performance, 60 to 79% moderate performance, and greater or equal to 80% good performance. We discovered that the attribute system reveals that these are the definitions of the system attributes. We discovered that the usefulness was the highest with 95%, and the predictive value positive was lowest with 76.7%, and the other attribute ranges from 65 to 89.5%. The case fatality ratio was 1.7, and this is the map of Ogun State highlighting the COVID-19 confirmed cases from April 2020 to May 2021. It showed that most of the LGAs that borders the epicenter of COVID-19 in Nigeria, which is Lagos State, have cases of more than 100 cases to greater than 428 cases. The monthly distribution of confirmed cases reveals that during the first lockdown period after the first wave of COVID-19 pandemic, cases started increasing from mid-April to mid-June and reduced in mid-July when lockdown was eased. The second wave began in mid-December and peaked towards the end of February, and the second lockdown was instead in March 2021 when the cases were decreasing. The age-gender distribution revealed that the female within the age group of 25 to 29 were the most affected, and the males within the age group of 30 to 34. The COVID-19 surveillance system in Ogun State exhibits attribute of moderate performance, which limits prompt reporting of cases and limits changes made to reporting method because the effectivity was 65%. The system made the initial objective of the surveillance ineffective in the early detection of cases in the community through periodic testing and targeting suspected people and persons of interest, especially people coming from the epicenter, Lagos State. The system met the objective of early case detection, and it was found to be useful because it detects in a way that permits early treatment, prevention, and control. The system also provides estimate of morbidity and iteration of cases associated with COVID-19 and mortality, which is the case indicator of the overall performance of the pandemic. Data generated permits assessment of effect of prevention and control programs that led to improved clinical, behavioral, social, and policy and environmental practices. There was no functional laboratory in the state for testing COVID-19 samples at the beginning of the pandemic, and the attributes of the system were assessed were commendable and possessed quality characteristics that have contributed to early detection and identification of COVID-19 cases in Ogun State. The predictive value of the system was low, indicating that large numbers of people with false positive will be invariably confirmed to have COVID-19. We recommended that the Ministry of Health Public Health Department should ensure that COVID-19 surveillance activities are fully funded with minimal dependency on partners, and all personnel involved at all levels should be periodically trained and mentored to improve system data quality and consistency in reporting, and provision of logistics should be available, and provision of tools should be available all the time. And we recommended that strengthening and expansion and full duration of COVID-19 system to all world level. I would like to acknowledge the NCDC, AFENET, Nigerian Field Epidemic Laboratory Program, Ministry of Health, Epidemic Unit, and Federal Ministry of Agri and Food Security. Thank you very much.
Is the surveillance system acceptable? Is it robust? Can you keep on changing it? He's done a good job. And then and then about self-medication. In that one we saw the people who actually should be going to hospital are the ones self-medicating. So short Q&A session, and then we'll allow just 3 questions, and then we get to part B. Thank you. Any? Yeah, I see 1, 2, 3. Yes, we are done. Yeah. Mike. you so much. My question was, did I conduct a study during COVID times? Yes, I did this study during 2021, and it was the whole year.
Second wave, but then also how we handled recall bias was, one, we were asking whether someone, of course, had experienced COVID-19 either by PCR or self-reported. So we would go into the records to really find out really whether someone suffered from a condition. But also don't forget to remember that when I've experienced something or I've undergone I've ever suffered from a disease, it is easier to recall than if I've never suffered from a condition. So a recall period of 1 year, it was really easy to recall. But however, we still went into the documents to review the PCR results. Thank you.
Thank you, thank you. Yes, I want to thank the audience for the questions. Really, it enlightens the whole study, and it makes me also appreciate it much better. So a question from Anne. She asked what type of test. This was a COVID-19 antigen test, which was a rapid test. It was not PCR. So it's something which really we also acknowledged as a limitation to a certain extent, but that's what was available and it's what was being used at the center. Then for the conclusions, I didn't mention that lack of face masks. It was rather not using face masks among refugees. And I did present the factors associated with this infection among refugees, as it was illustrated in figure 4. Yeah, and maybe if I can just recap, it was being close to someone who had symptoms of COVID-19. It increased the odds by 10 times. And also using face masks reduced the odds of infection by more than 90%. Then another question, I didn't get the name well. It was about why there was a delay in response at a national level. So as I mentioned earlier, at a national level, we received this alert through media, which was on 21st June. And we had to swing into action on 26th June. However, when we got on ground, we found the district and the transit center leadership and clinical team were responding and managing this outbreak at the district level. So we had to join efforts to enable this investigation move faster, such that we can be able to implement the control measures and reduce the infection. So the delays in there, probably the district thought they would contain this, but good enough, the alert came through up the Ministry of Health. Thank you.
Okay, thank you. Aristide, tell us about Burkina Faso men.
Okay. La question posée est de savoir pourquoi les hommes acceptaient plus la vaccination comparée aux femmes. Déjà, il faudrait dire qu'au Burkina Faso, il y avait une mauvaise compréhension sur la vaccination contre la COVID-19, ce qui faisait qu'il y avait la peur au sein de la population. Et parmi cette peur, il y avait aussi la crainte de la stérilité, ce qui faisait qu'il y avait une certaine interdiction que les hommes donnaient aux femmes de se faire vacciner. Donc c'était un peu ça. Merci.
Ok, merci.
Non, c'est pas scientifiquement prouvé. C'est juste une hypothèse dans la population qui dit que la vaccination, ils n'ont pas la fiabilité de la vaccination en fait.
Ok, merci. Adesoji, what you're being asked is about those other attributes like sensitivity, predictive factor, those ones.
Thank you very much for listening and thank you for the wonderful question. And I would like to engage after, if I didn't answer it well, after you can see, contact me and I will answer you. But actually we evaluated all the system and attributes of the community system, and the laboratory company was the positive value, which was low because there was no functional lab in the state then. Samples were being sent to
questions. Thank you very much.
Okay, you can see him after this. In Kenya, we say you can meet him behind the tent. Okay, thank you. Let's clap for them.
Before ask to the evaluator, we should influence first because for the time respect, all the presenter have made maximum 5 minutes. Donc you have to give the maximum, not for him. Without. Okay? I say without influence. My presenter is are very well. Good. Pour la seconde phase, nous avons aussi 6 présentations, 2 sur le SRAS et 4 sur la COVID-19. Chaque présentateur a 5 minutes et je souhaite qu'il respecte le temps et qu'il soit aussi clair que le présentateur. Mon collègue va vous annoncer en anglais les différentes présentations.
Thank you, Prof. So we now move to part B of this session, and we are going to start with Grace Funsani. Grace, good. Good afternoon, ladies and gentlemen. I'm Grace Funsani from Zambia AFETP. I'll present to you the prevalence of SARS-CoV-2 infection in the influenza-like illness and severe acute respiratory infection sentinel surveillance system in Zambia from January 2021 to December 2022. So Zambia has been implementing the influenza surveillance sentinel system since 2008 in order to monitor the circulating influenza virus strains in the country. So the system is conducted among the influenza-like illness, allies, and the severe acute respiratory infection patients who visit these sentinel sites. So by December 2022, the system had 14 sites distributed in 6 provinces as in the map below. So in this study, we wanted to demonstrate the use of this system to monitor the prevalence of SARS-CoV-2 in Zambia. We also wanted to compare SARS-CoV-2 trends in ally and SARS surveillance system and the national data, and also assess the factors associated with testing SARS-CoV-2 positive. So we analyzed data from the 14 ally sentinel sites from January 2021 to December 2022. So this data is collected from patients after taking a nasal or pharyngeal swab and filling a case investigation form after a verbal consent. So all the data from the case investigation form and from the lab tests are entered into a database. Ally in this study was defined as any case or any patient with fever 38 degrees or above and cough of 10 days or less, while a SARI was defined as an ally that required hospitalization. So basically an ally was an OPD case, a patient department patient, while a SARI could be inpatient case. COVID works were also defined according to the national case surveillance data in the calculated SARS-CoV-2 proportion positive specimen among the patients. Logistic regression was used to measure the odds of testing SARS-CoV-2 positive during the wet periods as well So out of the 7,279 patients that were recruited and tested for SARS-CoV-2, 42.5% had ILI and 37.8% had SARI. And 51.2% were males, and the median age was 17.4 years. So overall, 9.1% of the tests that were done, they tested SARS-CoV-2 positive. And below is the trend of the SARS-CoV-2 cases in the ILI system. We see there are peaks in February, in June, December 2021, as well as July 2022, which is consistent or similar to the national data graph as shown. We also saw that patients that were recruited during the wait periods, as well as patients above 5 years of age, and those who reported to have active TB, tuberculosis, had greater odds of testing SARS-CoV-2 positive. So in conclusion, we saw that the ILI Sentinel surveillance system in Zambia found COVID-19 cases with peaks that were similar to the national trend, which is demonstrating that it's a valuable system to monitor SARS-CoV-2 circulation in Zambia. This system could also be used to monitor other respiratory systems that are common in Zambia. Thank you very much.
Le prochain présentateur va nous parler des facteurs associés à la gravité de la COVID-19 chez les malades hospitalisés dans la ville de Goma, République démocratique du Congo. Vous avez la parole pour 5 minutes. Merci beaucoup pour la parole. Mesdames et messieurs, bon après-midi. Nous profitons de cette occasion pour présenter une synthèse des sujets que nous avions étudiés dans la ville de Goma, intitulé Facteurs associés à la gravité de la COVID-19 chez les malades hospitalisés dans la ville de Goma du mois de mars 2020 à septembre 2021. En guise de l'introduction, nous savons tous qu'en décembre 2019, il y a une émergence d'une nouvelle maladie de SARS-CoV-2 qui a donné lieu à une épidémie, à une pandémie de la COVID-19. Cette pandémie qui a mis sous tension tous les systèmes de santé pratiquement de tous les pays, même les pays les plus développés. On a vu les malades pris en charge dans les couloirs. A fortiori, il y a des pays qui ont encore des petits soucis. Nous avons vu ça impacter suffisamment les systèmes culturels de tout le monde et les socio-économiques avec des conséquences graves sur l'économie du monde. C'est la raison pour laquelle nous avons étudié cette maladie qui, vous le savez, au 31 août 2021, a tué environ 4 500 000 personnes à travers le monde. Et à leur décès, c'est environ 1059 personnes qui étaient décédées à travers ces temps-là. Et la moitié de ces 1000 personnes décédées étaient au Nord Kivu avec 500 malades qui étaient décédés dans les hôpitaux. Et la ville de Goma elle-même a dû contribuer à 25% de toute la mortalité de la RDC. C'est la raison pour laquelle nous avions voulu déterminer les facteurs qui sont associés à la gravité de cette maladie-là. Quelle est la méthodologie que nous avons étudiée? Comme nous avons dit, le site d'étude c'est la ville de Goma et le type d'étude c'est une étude transversale analytique des dossiers de malades hospitalisés dans la ville de Goma. Par rapport aux analyses statistiques, nous avions comparé les variables catégorielles restauration de la normalité par les tests de conséquences. Toujours dans la méthodologie, nous sommes partis de la définition de l'OMS qui divise en 4 les cas de Covid-19 et nous avons réduit à 2 pour des raisons opérationnelles. Pour des raisons opérationnelles et les cas moins sévères et les cas plus sévères. Les cas moins sévères étaient constitués des cas légers et modérés de l'OMS et les cas sévères étaient constitués des cas critiques et les cas sévères de l'OMS. Ce qui nous a poussé d'avoir les résultats suivants. À travers la régression, nous avons sorti 3 variables qui sont associées à la gravité Covid-19, la prise des produits traditionnels. Cette variable, qui est pratiquement une nouveauté que nous avions trouvée dans notre étude, est probablement liée au fait que la consommation de produits traditionnels aggraverait la cascade inflammatoire, aurait une toxicité sur les reins et sur le foie, mais aussi favoriserait la survenue de ces infections bactériennes. Nous avions mis en évidence les taux de protéines C réactives qui augmentent les risques quand ils sont au-delà de 6 mg par millilitre, d'environ 9,94 fois les risques. Ceci est le reflet par excellence que la COVID-19 c'est une maladie inflammatoire par excellence. Après, la fréquence respiratoire qui lui-même est le reflet de l'atteinte respiratoire de la maladie, c'est une maladie purement respiratoire. L'âge moyen de nos malades était de 50 ans, l'âge médian était de 50 ans, avec un espace interquartile entre 34 ans et 65 ans. Les cas graves représentaient 33% des hospitalisés. Pourquoi 33%? Parce que, tout simplement, au début de l'épidémie, tous les malades qui étaient positifs dans les guichets voyage, on les mettait dans des hôpitaux pour observation ou comme une quarantaine. C'est la raison pour laquelle la situation s'est passée de cette manière-là. En conclusion, nous disons que notre étude a permis de mettre en évidence 2 facteurs de risque, un facteur qui est modifiable, c'est la prise des produits traditionnels, et 2 facteurs qui sont non modifiables, la CRP élevée et aussi la fréquence respiratoire élevée. Ce qui nous pousse à dire qu'une sensibilisation contre l'usage des produits traditionnels réduirait sensiblement la prévalence de la gravité Covid-19 dans la ville de Goma. Nous avons dit et nous vous remercions. Merci. Merci. La prochaine présentation concerne les investigations de cas de Covid-19 dans le district de l'information au Burkina Faso. Vous avez 5 minutes pour votre présentation.
Bonsoir, chers évaluateurs. Bonsoir, chers mentors. Bonsoir, chers participants. Nous sommes Alima Clarisse, médecin, épidémiologiste en fin de formation du Burkina Faso. Nous avons le plaisir de vous présenter ce soir la synthèse de notre travail sur investigation des cas de Covid-19 dans le district de Nord-Massé au Burkina Faso en 2023. En introduction, on peut dire que la Covid-19, c'est une maladie infectieuse causée par le coronavirus 2 du syndrome respiratoire aigu sévère. Vu l'ampleur de la maladie et les risques de santé publique dans les autres États du monde, l'Organisation mondiale de la santé l'a déclaré en janvier 2020 comme une urgence de santé publique de portée internationale. Et là, nous vous montrons une vidéo de la COVID-19. Il faut dire que dans le monde, plus de 507 millions de personnes ont été infectées, avec plus de 6 millions de décès. Et le Burkina Faso n'est pas en marge. À la date d'avril 2022, toutes les 13 régions du pays étaient touchées, avec 20 885 cas confirmés et entraîné 384 décès. Il faut dire que la surveillance de la COVID-19 évaluateur, notre méthodologie, le cas d'étude était le district de Nongomasa avec 2 établissements scolaires, l'un primaire et l'autre secondaire. Là, c'est la carte du district. Et nous avons mené une étude transversale descriptive entre le 17 février au 13 mars 2023. Et nous avons sélectionné le 2 cas en tenant compte du voisinage des cas confirmés avec ou sans signes cliniques, des cas suspects avec des signes cliniques, également une recherche active par visite au domicile des cas confirmés. Nous avons effectué des prélèvements de séquestration pharyngée et réalisé des tests rapides de COVID-19. Quant au suivi des contacts, nous avons d'abord identifié, ensuite fait la liste des cas et l'évaluation de l'état de santé quotidiennement par appel au niveau des différents établissements scolaires. Et nous avons fait, après collecte des données, nous les avons analysées avec le logiciel EpiInfo et les données ont été présentées en termes de temps, lieu et personne. Chers évaluateurs, au résultat, il faut dire qu'au total, il y a eu 2 éclosions distinctes de COVID-19 dans le district de Nongomasa. Et avant le 17 février, c'est-à-dire avant notre investigation, le premier foyer avait 2 cas positifs et le second foyer 5 cas positifs. Et tous avaient en commun le cas index qui était un monsieur de 56 ans. À la date du 17 février au 13 mars, au premier foyer, avec 27 cas suspects, nous avons eu 2 cas positifs, ce qui ramène un total de 4 cas positifs pour le premier foyer. Quant au second foyer, avec 23 cas suspects, nous n'avons plus eu de cas positifs, ce qui maintient à 5 cas positifs au second foyer. Au total, 10 cas confirmés ont été notifiés et l'âge moyen était de 32 ans. Quant aux caractéristiques socio-démographiques de nos cas, il faut dire que le sexe féminin était prédominant avec 90%, suivi de la résidence en milieu urbain avec 80%. Notre cas index était un directeur. Suivi du lavage des mains avec 60%. Chers évaluateurs, en conclusion, il faut dire que l'investigation a permis de confirmer l'épidémie de COVID-19 dans le district de Nongomasa. Et à travers le respect des mesures de protection, mieux la collaboration franche et efficace des différents directeurs des établissements ont permis de circonscrire l'épidémie. Présentant ces images. La première, nous sommes en train de réaliser un test de COVID-19 et la seconde, une action de santé publique par l'un des membres de l'équipe d'intervention rapide du district. Chers évaluateurs, chers participants, nous sommes au terme de notre présentation et nous vous remercions pour votre aimable attention. Thank you, Clarice. That energy is what we need at this time. So next we have Jean-Paul from Rwanda. Is he in?
I think we should be looking at that when you are taking traditional medicine, come here, yeah. You have a higher risk.
Yes, of course.
Okay.
Merci beaucoup. La plupart de mes questions étaient en français. Je sais que je vais m'exprimer en français. Il y a aussi des traducteurs. La première question était de savoir que M. Kosma est en train de bannir la médecine traditionnelle en Afrique. Nous, on doit être clair, ce n'est pas ça du tout. Ici, nous avions mettre dans son contexte. C'est un contexte de Covid-19. Covid-19, c'est une nouvelle maladie. Je ne sais pas si on se comprend. Nouvelle maladie. Même la médecine occidentale n'avait pas de solution. Alors, Alors, vous allez me dire comment vous n'avez pas donné un jugement des valeurs contre la médecine traditionnelle. J'ai fait juste une association. Que le malade que nous avions reçu, qui était en stade grave, sévère, la plupart d'entre eux étaient exposés à un produit qu'on n'a même pas pu déterminer. Dans l'anamnèse, on dit, il est automédical à la maison avec des produits traditionnels. Une association n'est pas une causalité. Ça doit être clair en plus. Ça veut dire, quand on analyse en profondeur, je n'ai pas donné un jugement des valeurs contre la médecine traditionnelle. Je pense que j'ai été clair. J'ai dit que la sensibilisation, n'est-ce pas, dans ces cadres de la COVID-19, les médicaments là, doit être évité. C'est juste ça. Je n'ai pas donné un jugement contre, non. Je ne suis pas contre la médecine traditionnelle. La médecine traditionnelle a fait ses preuves dans beaucoup de maladies. Je suis médecin de longue date, je sais ce que je dis. Alors, par rapport à la question de la méthodologie, nous avions utilisé les données secondaires, bien sûr, et rétrospectivement. L'interlocuteur ou l'auditeur voulait savoir si ça ne pouvait pas entacher la qualité. Je suis d'accord avec toi et que les grands billets des données secondaires ou les données qu'on récolte dans les dossiers des malades ont un problème de qualité et de précision. Je suis d'accord. Mais pour autant, on ne peut pas ne pas les utiliser. C'est sûr, si c'est encore plus intéressant, on pouvait faire maintenant une étude qui soit prospective, n'est-ce pas, qui va récolter maintenant auprès de malades de façon beaucoup plus précise et bien mesurer ces variables-là. Une autre question, je ne sais pas si j'ai oublié une question par rapport à... C'était quoi la question? Association n'est pas voilà, la fonction rénale, c'est vrai, dans les dossiers des malades, c'était un bilan qu'on faisait. Quand on analyse en profondeur, mais nous n'avons pas pu faire une corrélation entre la fonction rénale et la prise des médicaments traditionnels. Mais il s'est fait que dans les hypothèses que nous avions données probablement qui pouvaient expliquer cette sévérité, nous avions parlé d'une toxicité. C'est vrai, dans les vous le savez, Covid c'est une nouvelle maladie. Mais nous n'avons pas dit tout le monde est ignorant. Que ce soit la médecine traditionnelle, que ce soit la médecine moderne, la fonction rénale et la prise nous le dit des médicaments traditionnels. Et que c'est fait que dans les hypothèses que nous avions probablement qu'on a donné des médicaments qu'il fallait pas cette sévérité, nous avions parlé de ces malades-là et qui peut aggraver la situation des nouvelles maladies. C'est au fait ça, c'est comme ça qu'il faut comprendre la situation. Que ce soit la médecine traditionnelle, que ce soit la médecine moderne. Ça, nous devons nous le dire ouvertement. Et que probablement qu'on a donné des médicaments qu'il ne fallait pas donner, n'est-ce pas, pour ces malades-là, et qui peut aggraver la situation des malades-là. C'est au fait ça, c'est comme ça qu'il faut comprendre la situation. Merci.
Parce que quand on parle de médecine traditionnelle, c'est quelqu'un qui a été reconnu comme étant un praticien traditionnel avec publié. Et dans votre étude, vous n'avez pas dit qu'ils sont allés voir un médecin traditionnel. Vous avez dit qu'ils ont utilisé des produits traditionnels. C'est différent de la médecine traditionnelle. Je crois que quelqu'un qui a été reconnu, publié, il faut revoir comme étant la forme de présentation traditionnelle. C'est ça que je voulais. Et dans votre étude, vous n'avez pas dit qu'ils sont allés voir un médecin traditionnel. Vous avez dit qu'ils ont utilisé des produits traditionnels. C'est différent de la médecine traditionnelle. Je crois que pour que ça puisse être publié, il faut revoir la forme de présentation que vous avez faite. C'est ça que je voulais vous conseiller.
For example, I'm just giving for example. Anyway,
thank you, Prof, for that. The other thing could be traditional medicine would have been a confounder. People who are taking traditional medicine.
We are with you. We are with you. So it's but clearly you can see this room. We are 90% traditional medicine. Higher. For example, I'm just giving Clarice. What came first? How did you know? How did you know this was the index case?
Merci pour l'intérêt porté à notre présentation. Par rapport à la détermination de notre cas index, il faut dire que nous avons déterminé notre cas index En tenant compte de l'itinéraire des cas confirmés, de la date du début des symptômes et de la date de leur diagnostic. Merci pour l'intérêt. C'est ainsi donc que quand nous sommes arrivés au niveau du premier établissement scolaire, à la détermination de notre cas, il y avait deux filles qui étaient positives. Et la première avait été dépistée à la date du 10 février 2023 avec sa voisine qui était dépistée le 12 février 2023. Et la première avec son père qui de retour d'un voyage en France qui était positif. À la date du 2 janvier 2023 a été dépistée à la date du 8 février 2023 avec sa voisine de son retour de voyage en France le 12 février 2023 a été dépistée le 8 février 2023 qui de retour confirmée à la COVID-19. À la date du 2 janvier 2023, lorsque nous sommes arrivés, il y avait 5 enseignantes qui étaient positives et la première enseignante de son retour a été dépistée le 14 février 2023 et a été dépistée qui était la voisine proche de la première fille dépistée à la date du 12 février 2023. Et c'est ainsi donc, en partant de leur itinéraire, comme je l'avais dit, leur date de début des symptômes et leur date de février 2023 et avec sa fille notre cas qui était la voisine proche de la première fille dépistée à la date du 12 février 2023. Et c'est ainsi donc, en partant de leur itinéraire, comme je l'avais dit, leur date de début des symptômes et leur date de diagnostic, nous avons pu déterminer notre cas index.
Which site was more prevalent in SARS-CoV-2? The sites on the copper belt of Zambia were the ones that had more SARS-CoV-2, and especially the Arthur Davison Hospital. Thank you very much. Which site was more prevalent in SARS-CoV-2? The sites on the copper belt of Zambia were the ones that had more SARS-CoV-2, and especially the Arthur Davison.
You asked a question about the vaccination in Namibia. I think it was for interest sake. It started in April 2021. Okay, and then for the question of the isolation facility, in my presentation, I mentioned that it was the only health facility with an isolation facility during the pandemic. So currently, as we speak, in Namibia, every district now in Kavango East has an isolation facility. So I think for the question of the isolation we have learned from the pandemic. In my presentation, I mentioned that it was the only health facility with an isolation facility during the pandemic. Okay. So currently, as we speak, every district now in Kavango East has an isolation facility.
The question was
asked on
I think the reason for the peak
we have learned from the pandemic. Thank you.
Okay. So in April 2020, there was a 21-day for my question period of lockdown. Just after which the restrictions were eased. The question was asked on that's the reason for accounted for the increase in cases in June. So and also with the increase of cases in January, that was just before the festive season period of lockdown. And after which the restrictions were eased. Ghana, we engage in a lot of festive seasons such as Christmas and the increase in a lot of social activities in June. So and that's also accounted for cases in January, the increase in cases. That was just before the festive season. And
okay, I want
Ghana,
you to clap for each of
you
because
so that's also
you are the best participant in the session, I know.
Thank you.
Thank you. Okay, I want you to clap for each of you because you are the best participant in the session, I know.
So, as you,
thank you.
Please remember to scan those barcodes and evaluate that particular session. Thank you very much, and thank you to my co-moderator, to the evaluators, and to the rapporteur. Prof, we are not taking a picture with the presenters. It's too late. Please remember to scan those barcodes and evaluate that particular session.
Good evening. The concurrent oral session. We want to keep pushing so that we don't have backlog of presentations as we move. Yes,
I want
so
to
this
do,
is the
please, we can
last,
stretch for 3 minutes, but let me do a quick run to be sure we have our presenters here.
Oral session.
Do we have two? Anu Olapo Afolabi. Anu Olapo Afolabi. Please, we can stretch for 3 minutes,
guess from
but
Nigeria.
let me do a quick run to be sure we have
Brian
our
Agaba.
presenters here.
Okay, please, can we come forward so that we
Anu Olapo
save time?
Afolabi.
Emerance Hirwa.
Anu Olapo Afolabi.
See, thank you. I guess from
Kwabale
Nigeria.
Duba. Brian Agaba.
Please, thank you.
Good afternoon, ladies and gentlemen. My name is Brian Agaba, a field epidemiology fellow with the Uganda FETP. I'll be presenting findings of a study titled Trends and Spatial Distribution of Perinatal Death in Uganda. Good afternoon, from 2017 through 2021. My name is Brian Agaba. A perinatal death is defined as the death of a fetus after 28 completed weeks of pregnancy up to 7 days of life. It is the sum of stillbirth and early newborn death from 2017 through 2021. A stillbirth is the intrauterine death of a fetus. A perinatal death is defined after 28 weeks of pregnancy or one weighing more than 1,000 grams. The baby is born without signs of life, such as breathing movements and early newborn heartbeat and pulsation of the umbilical cord. Is the intrauterine death of a fetus are further subdivided into fresh stillbirth of pregnancy and macerated weighing more than 1,000 grams. A fresh stillbirth occurs around the time of delivery, while a macerated stillbirth occurs before labor onset, and the baby shows degenerative changes such as skin discoloration, peeling of the skin, and softening of tissues on examination. An early newborn death is when a baby dies after birth but before 7 days of life. And perinatal death encompasses all the above. Such as in Uganda, 80% of perinatal death are caused by complications of prematurity, birth complications such as birth asphyxia after birth, obstructed labor, and birth trauma, perinatal death, infections such as neonatal sepsis. In Uganda, pneumonia, 80% of perinatal death and congenital anomalies caused by complications of prematurity. In 2014, birth complications, the World Health Organization, through the Every Obstructed Newborn Action Plan, birth trauma, set a target for all countries such as neonatal to achieve a stillbirth pneumonia and meningitis, stillbirth and rate anomalies less than 12 deaths per 1,000 births, and a newborn death rate less than 12 per 1,000 live births by 2030. Set a target for all countries in Uganda to achieve the stillbirth rate by 2021 was 18 deaths per 1,000 births. And according to the Uganda Demographic Health Survey of 2022, newborn death rate stands at 22 deaths per 1,000 live births. These rates are above the World Health Organization by 2021 was 18 deaths. 75% of perinatal deaths are preventable through interventions before, during, and after pregnancy. Uganda has been implementing a host of interventions to reduce perinatal death. Key among these is the perinatal death surveillance and response, whose goal is to identify interventions before, during, and learn from each perinatal death. Uganda has been implementing a host of other interventions under implementations include increasing uptake of family planning, increasing antenatal care coverage, whose goal is increasing proportion of births attended to by a skilled birth attendant, improving emergency care of the small and sick newborn. Other interventions training health workers include in newborn resuscitation and improving utilization of antenatal care coverage, increasing proportion of births. Despite these prevention strategies, perinatal death in Uganda continue to be higher than the World Health Organization. Training health workers, understanding the trends and spatial distribution of perinatal death is essential in assessing progress towards targets. Despite these and evaluating effectiveness, perinatal death in Uganda continue to be higher than we set out to describe the trends and understanding the distribution and spatial distribution of death in Uganda from 2017 through 2021. And evaluating effectiveness. We abstracted data from the District Health Information System. Therefore, we set out this is an electronic database that contains data from all health facilities that conduct deliveries of babies. Perinatal deaths are reported by health facilities. We abstracted data and aggregated by district in which they occur. We abstracted data on from all macerated stillbirth, fresh stillbirth, early newborn death, live birth, total birth, and reporting rates using pivot tables in which they occur. We then performed Mankendo trends test to detect the presence of monotonic trends using Excel software. Live birth, ladies and gentlemen, these were our findings using pivot tables. From 2017 through 2021, 139,948 perinatal deaths were reported into the DHIS2. Macerated stillbirth and fresh stillbirth contributed the bulk of perinatal death at 38 and 37% respectively. This graph shows trends in perinatal death and reporting rates into the DHIS2 from 2017 through 2021. The y-axis on the left shows perinatal death rate. The y-axis on the right shows reporting rates. The red line shows trends in perinatal death, and the blue dotted line shows trends in reporting rate. The perinatal death rate declined from 28 per 1,000 births in 2017 to 19 per 1,000 births in 2021. This decline is likely to be real considering the high and consistent reporting rates during this study period. And this decline could be attributed to some of the interventions highlighted earlier in this presentation that have been implemented by the Ministry of Health and its partners. This graph shows trends in stillbirth and early newborn death. The y-axis shows death per 1,000 births. The blue line shows trends in stillbirth, and the red line shows trends in early newborn death. Over the study period, both early newborn death and stillbirth declined significantly, as evidenced by the Mankendo p-value of 0.03, which is less than 0.05. This graph shows trends in perinatal death in private hospitals versus government hospitals. We can see the perinatal death rate is decreasing in both private and government hospitals. However, private hospitals continue to report higher rates than government hospitals throughout the study period. This could be because public health interventions, such as those highlighted before in this presentation, usually begin and focus on government hospitals. Studies have also shown that the quality of care was better in government hospitals compared to private hospitals. This graph shows trends in perinatal death for the different levels of health facilities in the country. Regional referral hospitals have the highest perinatal death rates, followed by general hospitals. In fact, regional referral hospitals registered an increase in perinatal death rates during the study period. The higher rates of perinatal death rates in higher level facilities could be explained by 1. Lower health facilities refer complicated cases to higher health facilities. These are at an increased risk of death. 2. Perinatal deaths are reported at the facility they occur and not the facility of origin. These maps show spatial distribution of perinatal death by district for each year. The darker the shade, the higher the perinatal death rate in that district. The proportion of districts with perinatal death rates greater than 24 per 1,000, which is twice the WHO target, represented by the maroon color, decreased over the study period, as evidenced by the lightening of the maps as the years progressed. In fact, they decreased from 48% in 2017 to 20% in 2021, signifying gains across the country. Arua, Lira, Hoima, Kampala, and other districts with regional referral hospitals had perinatal death rates above 24 per 1,000 consistently throughout the study period. This again could be attributed to the fact that perinatal death rates are recorded in the districts they occur and not the districts where they are referred from. In conclusion, Uganda registered significant decline in reported perinatal death rates between 2017 through 2021. However, rates remain above World Health Organization targets. Private health facilities and private hospitals and higher level health facilities have higher perinatal death rates compared to the others. Districts with regional referral hospitals also had consistently high perinatal death rates. We recommend that the Ministry of Health and its partners focus on areas and health facilities with persistent high perinatal death rates. Interventions such as improving staffing levels, in-service training of health workers, improving quality of care could reduce the perinatal death rates in these areas. We also recommend epidemiological studies in these private hospitals and districts with high perinatal death rates to identify factors associated with this. These are our major references. We acknowledge the following institutions. Thank you for listening.
Please note your questions. We'll take them at the end of the presentation. Thank you, Brian. You saved us 1 minute. So let's move. Emerans. Will you be able to save us a minute as well? Emerans will be taking us through prevalence and associated factors of immediate postpartum family planning utilization in Yabihu district.
Good afternoon. So I'm Emerance Hirwa Igihozo, FETP resident from Rwanda, and I'm going to present my study about the prevalence and factors associated with immediate postpartum family planning in one of Lulo district area of Rwanda. As an introduction, when we say family planning, it is the practices of controlling the number of children by putting intervals or spaces between the children by using different methods. When we say immediate postpartum family planning, it refers to the initiation of the family planning within the 34 hours after delivery. And this is a good time to reach many women as possible, as they are still under health facility observations. And the family planning considered as a life-saving for both mothers and children, as it reduced the child and the neonatal morbidity and mortality and other health-related problems like unsafe abortions, the stillbirth, and other health problems. And my study aimed to determine what are the possible factors related to the immediate postpartum family planning and the prevalence. As methodology, this is a health facility-based cross-section study where one district hospital and 15 health centers of Nyabihu district in Rwanda were involved. And as inclusion criteria, all women who gave birth in the health facility from January to June were involved. And data were extracted from different patient files and registers. And the data collection, we used the Excel sheet to gather all related information. And in data analysis, the starter version 16 were used. Also, in data presentations, the proportion and the frequencies well calculated in descriptive analysis. Also, the logistic regulation well used in analytical. All factors which are below or equal to 0.05 were considered as statistical significance in bivariate analysis, and also transferred in multivariate analysis to control all possible confounders. And the study was approved by the ERB Institutional Review Board from the University of Rwanda, College of Medicine and Health Science, and also the District Hospital Ethical Committee approved to collect some data. All ethical procedures were followed. Where women names were not collected, we used the codes. Here come the results. As a result, based on the inclusion criteria, 1,682 women were involved, and among them, the 38% accept and use the immediate postpartum family planning. This is a descriptive result where more participants had the age between 22 to 29 years, and most did primary education, and around the half were Catholic, and almost like 93% were married, and about 77% were in the Ubudehe category. In Rwanda, the Ubudehe category are those classifications based on the socioeconomic status or the wealth status. In our country, we called Ubudehe category, category 1, category 2, and category 3. And these are the descriptive based on clinical characteristic, where more participants like almost had health insurances, and 88% attended the antenatal care visits. 88 also experienced the history, didn't experience the history of child mortality, and around 70 report to previously use postpartum family planning, and the 99.7% their serologic test is negative. Here comes the factors associated with immediate postpartum family planning. The 9 independent variables were statistically significant to the immediate postpartum family planning, where women with 14 years and above had like 70% less likely to accept the immediate postpartum family planning than others. And regarding the education level, those with the higher education level had 13 times more likely to accept the immediate postpartum family planning than others who attend other lower level of education. And regarding the marital status, those who are married, the chance of accepting the immediate postpartum family planning were around 2 times higher odds among married women than single mothers. And also regarding the category, the socioeconomic categories, those who are in Ubudehe Category 3, I mean the higher health status, had around 5.4 times more likely to accept the immediate postpartum family planning than those who are in other categories. Okay. Also, the attending the antenatal care visits is statistically significant to the immediate postpartum family planning, where those who attended the antenatal care visit while pregnant had around 8 times more likely to accept the immediate postpartum family planning. Also, the experience of child mortality seems to be a protective factor for the immediate postpartum family planning, where those who experienced some experience of child mortality had like 90% of less likely to accept the immediate postpartum family planning than others. Also, previous use of family planning is also statistically significant to the use and acceptance of postpartum family planning, where women who previously used the immediate postpartum family planning had 3.4 times higher odds of accepting than others. Also, the number of living children in the household also become a statistical significance to the immediate postpartum family planning, as the number of living children increases. Also, the chance of accepting the immediate postpartum family planning increase on 9.2 times higher. Here comes the discussion, just comparing the result with other study. The study presents lower prevalence compared to the other study conducted in Rwanda in one hospital called Kachilu, and the difference might be due to they use different methodology. Those one use qualitative method with a lower number of sample size, And also this is a hospital which is located in the urban area, while our study conducted in the rural one. Also the married women, as it is statistically significant to our study, it is approximately similar to the study conducted in Ethiopia. And also attending antenatal care visit, as it is very associated to immediate postpartum family planning. This study also was similar to the study conducted in Ethiopia, and the possible explanation here should be as mothers attended those kind of antenatal care visit, they get chance to get some more health services, counseling. And as a recommendation, we recommended just providing different health education, targeting the young and the single women from the findings. And also intervention should target the women with lower education and the lower wealth status. Also should strengthen the antenatal care visits and to strengthen different programs targeting reducing the mortality and morbidity of maternal and fetal. As a public health action taken, the findings helped different health planners and the policymakers to implement and develop other effective strategies to improve the family planning. Also, by now, the counseling on family planning was enhanced. Also, mothers by now are not reached only into the antenatal care visit, but in other health services. I acknowledge the following, and these are my references. Thank you.
Thank you, Emerance. We'll quickly take the next presentation. Factors associated with seeking skilled attendance services amongst women aged 15 to 49 years in North Horsab County, Marsabit, Kenya. Kwabali.
Good afternoon, everyone. My name is Anna Kabale Duba. I am a FELTEP resident from Kenya. My study is on factors associated with utilization of skilled birth attendants among women of reproductive age in Northern Sub-County, Marsabit County. Maternal mortality remains a major public health problem in developing countries. Globally, skilled birth attendants increased from 78% in 2014 to about 85% in 2021. Despite the increase, only 50% of live births in sub-Saharan Africa in 2016 were under skilled birth. Maternal mortality rates in Kenya declined from 362 in 2014 to about 353 over 100,000 live births in 2021 as a result of improved utilization of skilled birth deliveries. Marsabit County, which is one of the counties among the 47 counties in Kenya, despite the nation's decline, still has a higher mortality rate of about 3 times that of the nation. Only 28% of the women in Northern Sub-County where the study was done had skilled deliveries in 2018. That's according to the study done by Nyongesa in 2018. The objective of the study was to estimate the proportion of the women utilizing skilled birth attendants in Northern Sub-County, to determine the factors associated with utilization of the skilled birth attendants, and to describe the challenges experienced by women, by the pregnant women in Northern Sub-County while seeking the services. The methodology, the study area is Turbi Ward, which is in Northern Sub-County, Marsabit County, Kenya. The study population are the women of reproductive age from 15 to 49 years. The design were mixed methods, qualitative and quantitative data were collected. The data collection for the qualitative data, pre-tested questionnaire used, and for the qualitative, FGD and focus group discussions were done. For the thematic presentation, the county was Marsabit, and in Marsabit we have 4 sub-counties, that is Moyale, Saku, Nodhor, and Lesamis. And Saku, Nodhor sub-county was picked because of the low skilled birds attendance coverage. And from that ward, from that Nodhor sub-county, we have around 5 wards, and Turbi ward was still picked because of the low coverage of the skilled bird attendance, and the selection of the villages were done. All the 30 villages were selected for the study. For the data management analysis, data cleaning done in MS Excel, and the analysis was done in AP Info 7. For the univariate analysis, frequencies, proportions calculated for the categorical variables, medium, mean, standard deviation, and interquartile range for the continuous variables. The bivariate analysis, the odds ratio, 95% confidence intervals, and the p-values were calculated. And the factors, that is at the p-value of less than 0.2 at the bivariate analysis was taken to multivariate analysis. And for the qualitative data was analyzed thematically. Socio-demographic, for the results now, that is the socio-demographic characteristics. The age 18 to 27 had the highest percentage at 44.1. For the marital status for the women of the reproductive age who took part in the study, about 97% were married. And for the parity, the women with more than 3 children were at 34%. For the religion, it's almost the same, but Muslim was at 50.3%. For the educational level, the women with no formal education were at around 89%. The maternal occupation, the study participants who are housewives were at 93%. The place of delivery and the kind of assistance these women get during the delivery. The women who either delivered at home, on the way to the health facility, or at the TBA, which is the traditional birth attendance place, are at 58%. This means only 42% of the women delivered in the health facility under skilled personnel. For the factors associated with utilization of skilled birth attendants among the women of reproductive age, at the bivariate level, religion was one of the significant factors. And also monthly income of less than 1,000 was a significant factor, and also the distance from 5 to 10 kilometers. At the multivariate level still, 4 factors, which is religion, monthly income, distance, and accompanied by the husbands to the clinic, was found to be scientifically significant. The results of the qualitative data, some of the responses for the thematic areas, like where the women seek the delivery services, one of the key informants said, the first time mothers tend to deliver at a health facility compared to those already with the children. The multiparous who never had any issues in their previous deliveries prefer to deliver at home. Under the theme of distance to the health facility, one of the respondents said, we usually walk for more than 2 hours to health facility, which is about 15 kilometers, to get services. So as pregnant women, this is difficult for us. For the challenges faced by women, poor road networks and also insecurity in the county contributes for these women delivering at home. For the means of transport, the most reliable, which is motorbikes, is very expensive for the women to afford. The discussions, skilled birth attendance coverage, although increasing, is still low in the study area. More than half of the populations still deliver at home. The only few women who sought the skilled birth attendants are those who are financially stable, who live around the health facility, and those with complicated previous experiences in their pregnancies and deliveries. For the conclusions and the recommendation, the proportion of the women utilizing skilled birth attendance was low despite the services being free in the government facilities. The factors that are associated with the utilization of skilled birth attendance are the distance, religion, monthly income, and husbands accompanying women to the health facilities. So for the recommendation, advocacy by the county government for the utilization of skilled birth attendance should be done through sensitization of the religious leaders, also conducting outreaches for the women of reproductive age, and training of the and encouraging the traditional birth attendants to be acting as a referral agent instead of conducting the deliveries at home. To address the challenges of the distance, maybe construction of maternity shelters for these women. These are the pastoralist communities, so it's good for them to have shelters in these areas as they wait to deliver. These are some of the photos when we were doing the study. For the public health action, dissemination of the study finding was done at the county and also sub-county level, and as a result, referral system has really improved. Sensitization of religious and community leaders also took place at the facility and also village level. The traditional birth attendants were sensitized to refer the mothers to deliver at the health facility, not at homes. I acknowledge this team, that is Moi University, Kenya FELTEP, disease surveillance, the county, and also study participants. Asanteni sana. Thank you so much.
Thank you, Fabale. We've been listening to presentations on maternal health, right? It's supposed to be maternal, reproductive, and child health, but the presentations we've taken so far is centered around maternal health. I think we'll just go ahead and take the other presentations before we take questions for want of time. We're supposed to take questions now, but we'll go ahead with the other presentations. So, D-Day, you are? Okay, yeah, come forward. So you'll be presenting on assessment of neonatal sepsis among preterm infants in Yamata Hospital.
delivered your baby at a new hospital near the Cheese Palace. How did it go? The friend responded, yes, I delivered at a new hospital, but I regretted going there to deliver, considering how I was maltreated. Madam, how upon hearing this, became more confused. In the midst of this confusion, ended up giving birth to her baby at home, which subsequently led to the loss of her life and that of her baby within 2 hours after delivery. The loss of Madam Hawa and her baby did not only leave a devastating effect on the husband and family, but brought upon darkness in the whole community of Lengbong that fateful evening. Who do we blame for the loss of Madam Hawa and her baby? Do we blame her for choosing to give birth at home? Or do we blame her friend for giving her that information? Or do we blame the healthcare workers who treated Madam Abiba badly when she came to deliver? Let's ponder over these questions. And as we ponder, let's remember that as professionals in the health landscape, our actions and inactions does not only affect individuals, but communities, nations, and the world at large. Gafar Mohammed is my name, and I'm presenting on predictors of institutional delivery service utilization in the northern region of Ghana. Over the past 20 years, the government of Ghana has implemented various measures to improve deliveries inside the hospital setting. Some of these measures include introduction of the National Health Insurance Scheme, improvement in health infrastructure, and also despite all these measures, recent studies conducted in 2019-2020 revealed that about 40 to 50% of deliveries still occur outside the health facility setting. Data available on the District Health Information Management System for 2021 revealed that about 25% of deliveries in the northern region of Ghana were conducted outside the health facility setting. We all know deliveries outside the health facility setting is associated with numerous complications and consequences, including increase in maternal and neonatal mortality, decrease in immunization risk, among others. After exploring the numerous measures implemented by the government and the persistence of deliveries outside the health facility setting, we conducted this study to assess the prevalence of institutional delivery services and the factors that predict this phenomenon. We conducted a community-based cross-sectional study among women aged 15 to 49 years in the northern region of Ghana. The study was conducted among women who had a live birth between January 2021 to January 2022. The study was conducted in the northern region of Ghana. Northern region is one of the 16 regions of Ghana and is located in the northern part of the country. The region has 16 districts, with Tamale Metropolis being the regional capital. The region has over 60% of its population being in the rural setting, depending on health centers, children's facilities, traditional birth attendants, and herbal healers as their main source of health. This study was conducted among 310 women sampled from the region using a multi-stage sampling approach. The first stage of the sampling approach was the selection of 8 districts out of the 16 districts in the region. The second stage involved the sampling of 2 communities out of the previously sampled 8 districts in the region, and the last stage involved the sampling of women from these particular selected communities. Data was collected from these women via face-to-face interviews using a semi-structured questionnaire developed and deployed on Kobo Collect. We collected data on particular variables. This included the place of delivery for their most recent birth. Also, socio-demographic characteristics such as age, marital status, education, among others. Data collected was descriptively analyzed and a logistic regression analysis performed to assess the predictors of institutional delivery service utilization at a 5% significance level. Our findings. Out of the 310 women studied, 245 of them, that is almost 80%, delivered in the hospital setting. However, 21% of them delivered outside the health facility setting. So out of the 245 women who delivered in the hospital setting, majority of them were between the ages of 21 to 30 years. And also those who were married were majority among those who gave birth in the health facility setting. Now, considering delivery in the health facility setting and community or health facility level characteristics, majority of those who delivered at the health facility setting had a valid National Health Insurance Scheme or card. Also, majority of these women who delivered at the health facility setting reported positive attitude of healthcare workers towards them. That is almost 70% of them. In terms of the presence of skilled health personnel at post, whenever they visit the health facility, majority of the 245 women who delivered at the health facility setting reported that, yes, they normally see skilled health personnel at post when they visit the health facility setting. Our study revealed 4 factors to be significant predictors of institutional delivery services in the northern region of Ghana. These factors included community perception, marital status, attitude of health workers, and availability of skilled personnel. Women who were married had a 3.1 times increased odds of delivery in the health facility compared to those who were single. Also, women who reported positive or good attitude of health workers had almost twice increased odds of delivery in the health facility compared to those who reported negative attitude of health workers. To discuss our findings, our study revealed that almost 80% of women studied delivered in a health facility setting. This implies that about 20% of women are still being given birth to outside the health facility setting, exposing them to the risks and complications of deliveries outside the health facility setting. Our findings is consistent with the 2017-2018 Ghana Multiple Indicators Survey, which reported that about 73% of all pregnant Ghanaian women seek care from a health facility whenever they want to give birth. However, a similar study conducted in the Magibi County of Liberia reported an inconsistent finding, that is, only 10% of those studied utilized a health facility in their most recent delivery. Proceeding to factors that actually influence deliveries in the health facility setting in this study, the attitude of healthcare workers was one of them. And in the story given from the onset, one of the reasons why Madam Hawa actually delivered at home was because of the information she was given by her friend. And this was because of the way her friend was treated when she went to deliver at the hospital. Now, these findings is consistent with another study conducted in Liberia, which reported that as the attitude of healthcare workers improves towards their clients, seeking care during delivery or during labor in the health facility setting increased as well. To conclude, our study identified less than 80% utilization of institutional delivery services with multiple predictors. These predictors include being married, the presence of skilled health personnel at post, positive attitude of healthcare workers, and positive community perception. In terms of our findings, we recommend that the government of Ghana institute a policy reform with a well-defined care package targeting on married, pregnant women, and health workers' attitude. To contribute our quota to increasing deliveries in a hospital setting or in the health facility setting in the northern region of Ghana, we conducted the following activities. The first one was we engaged healthcare workers and members of the district health information management teams in selected districts in the northern region of Ghana, where we discussed innovative measures on how to motivate women to seek care from health facilities whenever they are in labor. We proceeded to engage the local community or the local authorities in the communities, which included the community chiefs, unit committee heads, assembly members, and household heads, where we discussed how to motivate women to seek care in health facilities whenever they are in labor. I wish to acknowledge the following people, that is my mentor, Professor Ines Kenu, and the following institutions. Thank you.
Thank you very much, Abdul Mohammed. Thanks for keeping us awake and engaged. It's not easy to be making a presentation at almost 7 p.m. So we'll take the next presentation. Paul? He's not around? Okay, so come up. I was going to say that saves us 10 minutes. So he'll be presenting on post-abortion contraception choices amongst women, Kolebu Teaching Hospital. Okay, another presentation from Ghana.
Hello, everybody. Good evening. My name is Paul Jani Edu from the Ghana FETP, and I'll be presenting on the post-abortion contraception choices among clients in the reproductive health clinic in the Kolebu Teaching Hospital, data gathered between 2015 and 2019. We know that about 44% of pregnancies globally between 2010 and 2014 ended up as unintended pregnancies, and 56% of these were aborted, according to WHO. The Ghana Health Service reported that in 2016, 1 out of every 6 Ghanaian women had an unsafe abortion. This was confirmed with the 2022 the Ghana Demographic Health Survey, which emphasized the same proportions. In 2019, unsafe abortions constituted to up to 9.2% of direct maternal mortalities in Ghana. We know that contraception prevents unwanted pregnancies, occurrence of unsafe abortions, and the cause of mortalities and morbidities. And yet, the prevalence in Ghana is at 6%. In the recent demographic health survey, it's also reported at 36%. And post-abortion period is very critical because most of these women came with unintended pregnancies and they want to prevent further pregnancies. And again, return to fertility has been reported to be as early as 8 days up to 2 weeks. And so we analyzed the secondary data among women or among clients in the Kolebu Teaching Hospital who received abortion care, and to understand the contraception choices and their associated factors among these women post-abortion. And this informed us to make some interventions to improve the uptake of contraception. It was an analytical cross-sectional study in Kolebu Teaching Hospital, which is the largest tertiary institution in Ghana and much of West Africa, providing services for clients across Africa. And in that year, or in that period, the reproductive health clinic saw over 21,000 women. The abortion records from January 2015 to December 2019 were abstracted from registers of the clinic, and we use variables like social demography, pregnancy history, abortion history, and the post-abortion contraceptive choices of the women. We de-identified data, cleaned it, analyzed using data. We defined our outcome variable as whether women accepted a contraception post-abortion or not. And we excluded records of all clients that reported any reaction to a contraceptive method. The limitation of that work is that we were not sure if these pregnancies that were aborted, which of them were intended or unintended pregnancies, and also the clinical indications for abortions were unknown among these clients. Descriptive analysis was done to estimate proportions and frequencies, and our inferential statistics estimated crude and adjusted odds ratios at 95% confidence level, and we would obtain institutional permission. Overall, 1,559 eligible abortion clients' record was used over the period, and the median age was 28 years. Now, this is very significant to know that more than half of these women were living with male partners. On this table, we see that teenagers represented up to 7.4%, and then women greater than 33 years were 23%. So it means that the at-risk mothers were largely about 1/3 of this population. And we see that, very importantly here, that just about 5% of the women had no formal education, which is also very good, means that most of the women were educated. Now, the first grand multiparous women are women who have had 5 or more deliveries, and realize that they reconstitute up to 4% of this population, which means that although they have over 5 children, they are still using abortion as a source of contraception. You need to catch these women and ensure that they are safe with contraception use. We see that 1/3 of these clients had at least had one previous abortion, which is very significant. And we know that the first and second trimester reported over 99% of the women, which should have informed the procedure of choice, which is manual vacuum aspiration, according to Ghana's contraceptive criteria. In the first graph to the left, we see that about 57.5% of the women accepted contraception following abortion, and out of these, 57.1% accepted long-acting contraceptive methods. We tried to assess what were the different choices, and we realized that intrauterine devices, injectables, implants, represented the significant modern contraceptive methods that were used by these women. And then we tried to also find out, of these women, which proportion of them had their male partners participating in contraception post-abortion, and realized that barely 1% of men accepted vasectomy. 0.1% accepted vasectomy. Now, we see here on this table that only about half of all adolescents accepted post-abortion contraception, which is of great concern because we need them as much as possible to prevent unintended pregnancies. And over here, we also realized that women with no formal education had a greater post-abortion contraception prevalence. And you see that the prevalence literally reduces with increasing education. That's a very interesting finding here. Among the employed, previous abortion, parity, all of these were significant at the bivariate analysis level. But we realized that only parity remained the independent significant associated factor to accepting post-abortion contraception. And we realized that with women having deliveries, 1 to 4 deliveries, and 5 or more deliveries, it increases actually. The odds of accepting post-abortion contraception increases among women compared to those who are first-time pregnant. In 2022, the argument was made about using post-abortion contraception rates for measuring utilization of person-centered care in abortion clinics. And in a multi-country study of over 300 cases, Ghana was isolated to have had a post-abortion contraception uptake of about 69%. Now, despite preaching contraception autonomy, we also realize that partner support and partner participation is key to allowing these women to accept. And studies in Ghana have shown that women who stayed with their partners or who were with partners had a greater odds of accepting contraception. In Kenya, it is known from studies that women were followed up post-abortion, and they realized that after 3 months, those who discontinued abortion discontinued because their partners opposed to it. And so this was important for us in our study to realize that males were not so much as involved in terms of participating in the whole contraception process. Almost half of the clients did not accept post-abortion care. And this will need some further exploration. And the low post-abortion contraception rates among teens was significant because in the current demographic health surveys, it is noted that teenage pregnancy is about 15.5%. And we need as much of these girls to accept abortion, contraception following abortion. We think that because of maybe stigma, most teenagers would likely not take up contraception because they will feel that they are branded as bad girls if they take contraception. It is also documented that educated women were more likely not to take post-abortion contraception. As in the work presented by our Kenyan colleague here, postpartum abortion was accepted more by higher educated women. But in this case, it was a reverse. And we think that the more women are educated, the more they more or less process, analyze side effects, and they're more likely not to accept it. And again, they are most likely to have a higher economic situation and are able to manage more children. So those who are not formally educated, who are said to be of a lower economic status, may be more likely to accept post-abortion contraception. And so we think that post-abortion contraception rates was more than half among our attendants. IUDs, injectables, and implants were modern contraceptions that were most preferred, and increasing number of deliveries remained an independent associated factors. We recommended some interventions to target and encourage male partners in accepting contraception choice, and also to educate the nurses. One of the key public health actions was to train nurses to enhance counseling services. And a follow-up study, so this study was between 2015 to 2019, and in later 2020, a study was done in Ghana, in that same unit, reproductive health unit, and it was noted that post-abortion contraception was 82%, which is over 30% increase from what we had measured in the secondary data. Thank you very much. These are our references, and we acknowledge these institutions.
Thank you very much, Paul. We'll now take the last presentation by Kone Saji Alain Togma. He'll be presenting factors. Oh, this is in French. Oh, wow. So let me stop, please. He will read out the...
Ok, merci. Bonsoir à tout le monde. Je suis Dr Tougma de FETP du Burkina Faso. J'ai le plaisir de vous présenter donc l'étude portant sur les facteurs associés à la survenue du paludisme chez la femme enceinte dans le district sanitaire de Garango au Burkina Faso en août 2022. Nous allons pour cette présentation suivre le plan IMRED suivant. Le paludisme constitue un problème de santé publique dans le monde et particulièrement au Burkina Faso. Il s'agit d'une maladie endémique qui touche environ 241 millions de personnes, dont 627 000 décès enregistrés chaque année selon l'OMS. L'incidence du paludisme chez la femme enceinte au Burkina Faso de 2018 à 2021 se présente comme suivant. Et au niveau national, l'incidence est passée de 507 à 573 cas pour 1000 femmes enceintes. Dans le centre-est, qui est une région du Burkina, elle est passée de 751 à 863 cas pour 1000 femmes enceintes. À Garango, qui est un district, l'incidence est passée de 843 à 668 cas pour 1000 femmes enceintes. Plusieurs stratégies ont été mises en place pour lutter contre le paludisme chez les femmes enceintes. En l'occurrence, le traitement préventif intermittent du paludisme à base de sulfadoxine pyrimétamine, ainsi que la distribution universelle de 1000 DA pour les femmes enceintes. Mais malgré ces stratégies, nous constatons une persistance du paludisme chez cette frange de la population. Et pour ce faire, cette étude s'est fixée comme objectif d'étudier les facteurs associés au paludisme chez les femmes enceintes dans le district sanitaire de Garango. De façon spécifique, il s'agira de décrire les caractéristiques socio-démographiques et obstétricales chez les femmes enceintes et aussi d'identifier les facteurs qui sont associés à la survenue du paludisme chez la femme enceinte. Pour pouvoir répondre à cette question, nous avons choisi comme cadre d'étude le district de Garango, qui est un district dans le centre-est du Burkina Faso. Et le schéma suivant présente donc les formations sanitaires qui ont été échantillonnées pour participer à cette étude. Nous avons effectué une étude cas témoins appariés du 9 au 18 août 2022 avec un ratio de 1 cas pour 2 témoins. La population d'étude était constituée donc de toutes les femmes enceintes ayant fréquenté les formations sanitaires du district de Garango du 1er mai au 18 août. Et comme définition de cas, il s'agissait de toute femme enceinte durant la période d'étude ayant eu un diagnostic de paludisme confirmé. La témoin, c'est toute femme enceinte durant la période d'étude n'ayant pas fait de paludisme au cours de sa grossesse. Et ces femmes ont été sélectionnées par échantillonnage aléatoire à 2 degrés, le premier degré pour les formations sanitaires et le deuxième degré pour les femmes enceintes. Et la taille calculée était de 354, dont 118 pour le cas et 256 pour les témoins. Nous avons utilisé l'entretien face à face avec la revue documentaire et l'observation comme la méthode de collecte. Et les techniques qui vont avec, c'est l'interview, l'analyse documentaire et l'observation. L'outil, c'est un questionnaire semi-structuré avec un matériel audiovisuel pour les prises de vue. Et nous avons effectué un pré-test dans le district de Koupela pour tester ce questionnaire. Les données ainsi collectées sur le terrain ont été saisies et analysées avec le logiciel EpiInfo et nous avons procédé à une régression logistique univariée en calculant donc l'estimateur load ratio avec un intervalle de confiance à 95%. Nous avons obtenu une autorisation du Comité national d'éthique et nous avons demandé un consentement éclairé avant chaque étape. Pour ce qui est des résultats, nous pouvons déjà constater que la tranche d'âge des 19 jusqu'à 29 ans constitue plus de 55% de notre étude. Et le deuxième trimestre ainsi que le troisième trimestre constituaient l'âge gestationnel les plus retrouvés dans plus de 86% des cas. Plus de 86% des formations sanitaires avaient environ 2 jours réservés à la consultation prénatale. Et 53% des formations sanitaires étaient en rupture de sulfadoxine pyrimétamine et 30% de ces formations plus élevés de développer le palu comparé à celles qui y dormaient. Et celles qui ne prenaient pas le SP, qui est la sulfadoxine pyrimétamine, avaient 2 fois plus de risque de développer le palu comparé à celles qui prenaient la SP. Également, les femmes qui ne respectaient pas le délai de prise de la SP qui était d'1 mois avaient 2 fois plus de risque de développer le palu comparé à celles qui respectaient ce délai. Mesdames et messieurs, il faut dire que l'association entre le fait de ne pas dormir sous moustiquaire nous pensons que nos résultats pourraient être expliqués par la réticence des femmes enceintes à dormir sous moustiquaire pour raison de confort, pour difficulté à respirer et pour le fait que les moustiquaires ressemblent à des tombes. Et également, nous avons la méconnaissance des effets secondaires par les bénéficiaires, raison pour laquelle elles ne dorment pas dessous. Et il y a également le non-respect de la stratégie de distribution et des MILDA aux femmes enceintes par les agents de santé. Parce que, normalement, au premier contact de la femme enceinte, elle devrait recevoir son MILDA, ce qui n'est pas effectif. Ce qui concerne la pour donner toutes les informations à ces femmes-là afin qu'elles puissent respecter non seulement les délais et dormir sous les moustiquaires. Également, il y a la non-effectivité de la stratégie des 8 contacts promulguée par l'OMS qui ne se fait pas dans le district. Et également, l'épineuse question de l'insuffisance du personnel qui ne permet pas d'offrir les consultations prénatales tous les jours de la semaine dans les différentes formations sanitaires. Mesdames et messieurs, nous pouvons retenir que la mauvaise observance de la prise de SP et la non-utilisation des MILDA sont associées à la survenue du paludisme dans notre contexte. Et pour cela, une sensibilisation de cette population sur ces facteurs lors des soins prénatals réduirait l'incidence du paludisme chez la femme enceinte. Et l'autre, c'est une augmentation de la disponibilité des services de SPN pourrait améliorer la compréhension des femmes enceintes par rapport à ces facteurs, puisque ça offre l'occasion à l'agent de santé de mieux expliquer ce qu'il veut transmettre comme message. Sur ce, je voudrais remercier l'ensemble des partenaires qui ont soutenu cette étude et qui nous ont soutenus jusqu'à présent. Sur ce, je vous remercie.
Thank you very much, Togma. We've heard from the 7 presenters. We've heard on determinants of abortion, trends and spatial distribution of perinatal deaths in Uganda. We also heard prevalence and associated factors of immediate postpartum family planning utilization. We also listened to the presentation on factors associated with seeking skilled birth attendance services by women. We also took the presentation on assessment of neonatal sepsis among preterm infants, and then predictors of institutional delivery, post-abortion contraception choices, and malaria in pregnancy. We're now going to take a few questions. Please, if you have a question for any of the 7 presenters, just put up your hand. I will ask that you go straight to the question. Please don't tell us the methods and and results of the presentation again. Let me see the hands, please. Who will help us? Where's the microphone for questions? Please mention the presentation your question is referring to.
Check.
Okay, let's start from the back. Yeah.
Thank you very much for the opportunity. My question goes to the presenter on the predictors of institutional deliveries in northern Ghana. The presentation talked about targeted actions that were done in both the community and then the health workers as well, since that was the main source of problem that were identified. I want to find out if he has had the opportunity to follow up on the public health actions to see if there has been a change in the system. Thank you.
Okay, next.
Thank you. My name is Peter, and I'm a medical epidemiologist by training. I have two questions. One goes to Abdu. Abdu, thank you so much for your lovely presentation. I know you talked about predictors, but I wasn't sure if you did a prediction analysis. So at the end, did you have like a model for predictors, or were you doing like an etiological study? And then the second question goes to Paul. I wasn't clear when you said that once you did the multivariable logistic regression, parity was the only factor that remained persistent and that was significant. Did you any chance look at any interaction factors? Because there'll be things like age that would affect that. I know you did check for confounding, but did you see anything to do with interaction? Thank you.
Next, there's someone, and then there's someone. We have two in front. There's one person there, and then.
Ok, merci. Je remercie tous les présentateurs pour la présentation. Je crois ma question c'est par rapport au dernier présentateur, donc sur le paludisme et la grossesse. C'est vraiment un thème qui a beaucoup retenu mon attention parce que c'est la même situation que nous vivons dans nos districts. Et là, moi j'ai vu à l'introduction par rapport aux stratégies qui sont utilisées pour lutter contre le paludisme, mais malheureusement ça n'a pas marché, à savoir le fait de dormir sous moustiquaire et puis l'utilisation de SP. En réalité, le palu, on ne peut pas, je pense qu'on ne peut pas lutter contre le palu sans l'hygiène du milieu. Ce n'est pas possible du tout, parce que lorsque nous passons nos gardes dans les hôpitaux, nous voyons effectivement des enfants, des mères qui dorment sous moustiquaires, mais les moustiquaires ne sont jamais bien utilisés. Et deuxièmement, les SP, lorsque on parle déjà de la gratuité, il y a rupture de SP, on ne prescrit jamais les SP aux femmes pour aller payer dans les pharmacies. Oui. Ok, donc je disais.
Ask the question directly.
Okay,
it's past 7 p.m.
Ma question est que ces stratégies peuvent vraiment lutter contre le paludisme seul, sans l'hygiène du milieu, sans prescrire les SP aux femmes pour aller payer dans les pharmacies, voilà, en cas de rupture de médicaments. Merci.
Next, there's one more person here. That's the last. Yes, after him, that's the last question.
Okay, thank you. I think I have very quick questions for the presenters. It has been a marathon. Brian, you recommended doing further studies in private health facilities for the causes of prenatal deaths. Did you consider first scaling up the interventions that normally come late to the private facilities? And then to the presenter from Rwanda on the immediate postpartum family planning, I saw all your variables were all significant and having the same p-values. Did you have any limitations in your data collection, given that this was a secondary data? And then for Anna, on the skilled birth attendants, was there significant difference, statistically significant difference between those who are skilled and unskilled birth attendants? And our representative.
Thank you. Thank you. Last question, please. Please ask the question straight.
La première question, c'est Abdou de Ghana. J'ai cru comprendre que y a près de 20% d'accouchements à domicile. Certainement, Je n'ai pas bien compris totalement les raisons. S'il peut revenir pour expliquer un peu pourquoi. Parce que le Ghana, le pays voisin du Burkina, on pense que le système de santé est très bien développé. La deuxième question, c'est Ougma, il a fait une très belle étude, 4 témoins. Je voulais savoir quels sont 4 témoins appariés. Quels étaient les critères d'appariement qu'il a utilisés dans son étude? Merci.
Okay, thank you. So the presenters, please, you come and respond to your question just as you presented. So the first person to present should come first.
Thank you very much for your question. I was asked whether I considered first scaling up the interventions that begin in government hospitals to private hospitals before the epidemiological study. And I agree, as you saw in the presentation, my first recommendation was to focus the current interventions in those hospitals and districts that still have high perinatal death. And after that, we could consider an epidemiological study to find out more why those areas and hospitals persistently report high perinatal death rates. Thank you.
Thank you very much for the question. The question was if I made some limitation data collection. The answer is yes. Once the data is extracted from patient registers and the patient file, there is some missing of some variables where the healthcare professionals don't complete some information. Thank you.
Thank you. My question was if there is a significant difference between the skilled and unskilled birth attendants. So from the studies, 42% of the women only 42% delivered in the health facility. So this means that 58% of the women delivered under unskilled delivery. So the unskilled delivery birth is still higher in the area.
Okay, thank you very much for the questions. So my first question was if there's an impact of the public health actions we implemented. So before I started the presentation, I did mention that data available on the District Health Information Management System had it that 25% of deliveries in 2021 were outside the health facility setting. So recent data, just before coming to this presentation, I actually went back to the system to check the data again. And currently we have, from January to September of this year, only 12% of home deliveries has been recorded in the region. Also for 2022, the 25% had reduced to 15%. So I can't say the public health actions we implemented caused this, but might have influenced this increase or this decrease in home delivery services. Thank you. So that's the first question. Now the second question, he did mention that Ghana is well developed with a lot of health infrastructures, so he doesn't understand why we still have 20% home deliveries. That is very true. And like I mentioned, despite all the measures implemented by the government, there was still persistence of our deliveries outside the health facility setting, which led us into conducting this study. So that will help us inform policy development so that we will not center everything on health infrastructure now. There should be other measures we should consider when we want to increase institutional delivery services. Now, the last question was on if we develop predictive models. So like I mentioned, we employed a logistic regression analysis, both the simple and adjusted, where we develop coefficients and odds ratios to help us determine the prediction or the role of each of our independent variables on the use of institutional delivery services. Thank you very much.
I think my question was to address the fact that even it was done on interaction at the multivariate regression level. So yeah, following bivariate, our interest was to just develop that predictive model. We didn't look at interactions of the different factors, but it was still quite instructive to know that even at that level, with increasing pregnancies, women had a greater odds of accessing post-abortion contraception. That was key for us, to identify those group of women, particularly when they have an abortion services. But I think it's an important thing to look at, and we'll look into it. Thank you.
Ok, merci à l'ensemble de ceux qui ont posé des questions. Et je suis d'accord avec celui qui a posé la question. L'hygiène du milieu est très important. Et en plus, les pays qui ont pu éliminer ont utilisé cette stratégie. Donc, pour cette étude, il serait bon vraiment que nous fassions une étude environnementale. Et comme au Burkina Faso, l'hygiène publique vient d'arriver au ministère de la Santé, et je pense que nous aurons à proposer quelque chose. Parce qu'un grand penseur disait que le problème de santé n'est pas seulement pathologique, mais également politique. Et ma deuxième question, c'était la gratuité du SP. Pourquoi il y a une rupture? Également, il y a une rupture parce que sur la chaîne d'approvisionnement, il y a des fois des possibilités que le médicament n'arrive pas à temps dans les districts, même quand ils commandent. Donc, cela peut entraîner des ruptures et c'est ce que nous vivons dans nos structures. Et pour les critères d'appariement, nos critères d'appariement, c'était déjà la formation sanitaire où nous avons sélectionné les femmes et également le village. Il fallait qu'elles soient du même village, de la même formation sanitaire. Voici les questions qui m'étaient adressées. Merci à vous.
Thank you very much. Thanks so much to all the presenters. I hope we learned a lot. Thank you to the audience for your patience and for your active participation. I tell you, I learned a lot. For instance, in terms of perinatal deaths, it's strange to hear that you have more deaths in the private facility than in the government facility, and you receive better care in government facility than in private facilities. Where I come from, you get better care in the private facility than you have more expertise in the government facility, but then you get better care in the private facilities because you're paying for it. You want to? So he said he didn't have a question. Yes. So do you want to ask him a question so he can answer? There is a question for him. Okay, please, thank you for saving us.
Hello. Yes, for Didier. You mentioned that pneumonia was classified as the most likely cause of the outbreak in the hospital. So I was wondering how you came to that conclusion, since there were only 2 lab-identified cases of pneumonia.
Yes, please come and respond to it quickly here.
Thank you for this good question. So we arrived to conclude that pneumonia was one of major causes of the outbreak in a hospital is after reviewing existing literature that showed that pneumonia, comparing also from the proportion of the identified species through the blood culture, we saw that the pneumonia, Klebsiella pneumonia, have a high proportion compared to other species. And by comparing to existing literature review, that showed that Klebsiella pneumonia is one of the major cause of acquired hospital infections. And that we conclude based on those findings. Thank you. Thank you.
Okay, thank you, Dide. Are you okay? Okay. So also the other thing I wanted to talk about for the person that presented on the postpartum contraception, asking TBAs to refer pregnant women to the facility. To be good to follow up and see if they are actually referring, because you are telling them to get out of job. So are they truly going to be referring pregnant women to the institutional facility for delivery? So it will be good to follow up. Thank you so much. Please, tomorrow we start at 8 a.m. Kindly come out early so that we'll finish on time. We have the cultural night tomorrow so that we don't move from presentation into the cultural night hall. We want to end early tomorrow. Thank you so much. Have a good evening.